blessings contesting for infertility committee, ma'am.
Very good. Good luck. Good luck.
Thank you, ma'am. Thank you, ma'am.
Madurai.
Yeah.
Ha, very good temples are there.
Yeah.
Madurai,
Yes,
huh?
ma'am. Yes, ma'am. Meenakshi temple is there.
Meenakshi temple, yes. I have been to that place.
Yeah. Please do come, ma'am.
South is all south temples. Or mandir, temple.
Yes.
Everywhere there is temple. Yes. Town of every town is full of so many types of temples.
Yes, ma'am.
Ancient temples. No?
Yes.
Mostly
Old
ancient
temples and
temples.
साधना मैडम क्लिनिक पे बैठे हैं कि घर आ गए?
No, ma'am, I'm here.
क्लिनिक?
Hello.
हाँ जी, क्लिनिक.
Am I audible, ma'am?
Home.
Yes.
No, her home and clinic both side by side.
same place.
Okay. ऐसे नीलम मैडम तो मुझे लगा शायद घर पे हैं.
नहीं, I mean
हाँ.
हमारे घर पे
उतना बढ़िया
क्लिनिक एक में है, इसलिए उसको
नहीं इतना अच्छा तुम्हारा सीढ़ी है.
बहुत सुंदर दिख रहा है. बहुत सुंदर दिख रहा है पीछे.
एक्चुअली अभी सनलाइट के कारण हम इधर बैठे हुए हैं कि अपोजिट डायरेक्शन से आ रहा है.
हाँ, बहुत गर्मी है यहाँ.
बहुत गर्मी है मैडम.
आज तो बहुत ज्यादा गर्मी है.
क्लिनिक में क्या हो जाता है ना कि मैंने बहुत डिस्टरबेंस होने लगता है, इसलिए
हमारे फिर एकदम कोई अपने सिर पे खड़ा हो जाता है, उसको मना नहीं कर पाते.
मैंने तो सुनाई पड़ रहा है, लगा दो.
जरूरत होगा ना तो लगा लीजिएगा.
Good evening, Roma ma'am. Good evening, Sadhana ma'am. Pallavi ma'am, good evening. Dr. Kalpana here.
Time. Oh, it is still.
Good evening, Kalpana ma'am. Dr. Sadhana here.
Good evening. Yeah, good evening, ma'am.
पल्लवी मैडम दिखे थे 2 मिनट के लिए, फिर
हेलो डॉक्टर कल्पना.
Good evening, ma'am. Good evening, ma'am.
गुड इवनिंग पल्लवी मैम का थोड़ी देर बाद फैन दिखने लगा था.
हाँ, वो मैं जरा सा चली गई थी.
कल्पना दीदी, आप इधर सुमन दीदी, आपके यहाँ भी बहुत गर्मी है क्या?
नहीं, मेरे यहाँ तो नहीं. रांची तो हिल स्टेशन है ना, हल्की गर्मी है जितना होना चाहिए.
यहाँ तो इन बिहार मुजफ्फरपुर में तो बहुत गर्मी है अभी.
नमस्कार.
नमस्ते मैम.
हाय आशा.
नमस्ते जी, कैसे हैं?
अच्छे.
हम लोग का कैसे है पूछना थोड़ा मुश्किल है अभी.
आपको एक बात बताऊं, अच्छे रहिए. हार जीत अपनी जगह है, अपन से जो करना है वो करना है. And just leave it, because if you invest too much in it, life is going to be difficult and your performance suffers.
मैडम एक्चुअली ना ये जो आप बोलते हैं, ये आप जब बोलते हैं, मैं मॉर्निंग में जब उठती हूँ that time I actually obey your words. जैसे जैसे दिन गुजरता है ना, then I am getting confused and then I am getting stressed.
Don't get confused. See, last time I lost the election, right? So I told somebody that ठीक है, मुझे पता है इनके करने से मैं हारी. All right. मगर मेरे साथ जो हुआ वो मेरा नसीब है. So I'm happy with whatever has happened to me. So you need to accept whatever is going to happen. Somebody will win, somebody will lose. अपना काम करो और खुश रहो.
Hi Kavita.
Namaste.
But it is everyone is undergoing same kind of stress. I think
Hello, Kavita.
really difficult. Regretting so much.
It's easier to say, but when you are at the same thing, na, you're going through the same environment.
I'm happy that
How would you
everyone
I've
is
been
having
through
same
it. I've
feeling.
been through it.
Neelam madam,
Even I've been
Pallavi
through it, and
madam,
this is my second time.
they are both are thinking what sort of things they are going through and what things they are doing. नीलम मैडम तो पक्के में सोच रही क्या कर रहे, मतलब ये क्या चक्कर है
हम
मैडम
लोग
इतना।
अभी एक नंबर नहीं पता चल रहा था, इतना स्ट्रेस दिमाग में, कहाँ से उनका नंबर मिलेगा हमें?
किसका नंबर चाहिए?
अरे बहुत
बहुत सारे चाहिए उनको, तो बहुत चाहिए। मैंने उनको बोला जितने हैं उतनों को ही लगा लो, ज्यादा तकलीफ मत उठाओ दीदी, जितने उतनों को लगा लो।
अरे ऐसा बात नहीं है, मैसेज डाल दो, सब कोई पढ़ लेता ही है।
मैसेज कैसे डालूं? नंबर है तब तो मैसेज जाएगा, नंबर ही नहीं।
लेकिन एक चीज है प्रणाम मैडम, लेकिन आशा जैन मैडम के बात से हम एकदम सहमत
है।
हैं। आशा जैन मैडम के बहुत अच्छी पोजीशन थी, ठीक है थोड़ा सा फिट है बस, कोई बात नहीं है, अदरवाइज आशा जैन मैडम तो बहुत डिजर्विंग कैंडिडेट थी। तो
आशा
चलिए
मैडम की ना एक बात बेस्ट थी कि जो एंड में लिखा हुआ वही होना है, कितना
बस
रो
जो
लो
ये लिखा
कितना
हुआ
भी।
ना, इसलिए कहीं पढ़े थे हम कि एक इंसान ने भगवान को बोला कि मुझे अच्छी किस्मत है और बाकी कुछ मत दे, अच्छी किस्मत है।
अरे
वैसी चीजें
अच्छी चीज कुछ नहीं होती है, कोई कॉइन ऐसा नहीं होता जिसका सेकंड साइड ना।
वो ऐसा होगा ना,
Wherever you
कविता।
are, whatever you are doing, there is going to be a plus and there's going to be a minus.
यस मैडम, राइट,
That is for sure.
टू साइड्स ऑफ, फ्लिप साइड्स ऑफ ए कॉइन।
Everything is there. तो जहां हो खुश रहना सीखो बस। Just relax and do whatever is required.
आशा मैडम, मेरे घर वाले तो अभी बहुत खुश चल रहे हैं, मैं
हाँ।
पूरी तरीके से तन मन धन से इसमें डूबी हुई हूँ। वो क्या कर रहे हैं मुझे कुछ पता नहीं होता है। वो उनको लग रहा है सबसे अच्छा टाइम चल रहा है, मम्मी खाना खा लो बोल नहीं रही, नहा लो बोल नहीं रही, उठ जाओ बोल नहीं रही, कुछ बोल ही नहीं रही है, अपना ही अपना काम करती रहती है, काम करती है, हॉस्पिटल जाती है, वापस आती, काम करती, सो जाती हूँ थक के। तो उन लोगों के तो पिकनिक चल रहा है आशा मैडम। वो तो अभी बीमार पड़ गया इसलिए 3-4 दिन से स्ट्रेस है, अदरवाइज तो बहुत मजे मार रहे थे सब लोग। मतलब
Even the tolerance of our family members are getting reduced and reduced.
I don't even say anything to my mates. Someone comes and said tomorrow I will not come. I say okay.
Nowadays nobody is talking to me only.
सुमन दीदी, पहले तो मैं इतना नाराज होती थी, कोई आके बोलता था ना कल छुट्टी करूंगी, मैं बहुत चिल्लाती थी, ठीक है मेरा काम कर। अब तो जैसे कोई आके बोलता है ना कल मैं छुट्टी पे हूँ, मैं ठीक है, उससे इससे बहस करके कहाँ मैं अपना सिर और दुखा लूं, इतना दुखाऊ पहले से। बहुत ही ठीक है, सब निकल जाएगा, सब इसको सबको पॉजिटिव, सब एक लर्निंग है, लर्निंग जैसे।
At least we are sharing our own feelings so that everywhere we are little.
Kalpana, you are so strong. Me and Kavita Baranwal, we both are एकदम new.
I've been undergoing this stress for a long time.
Rajeshri madam, namaste.
Namaste, ma'am.
Rajeshri madam, namaste madam.
राजश्री, कैसी हो? आवाज नहीं आ रही है इसकी।
She has not started her volume. She's not connected to audio.
ठीक है, कोई बात नहीं।
पटेल सर नमस्कार।
अच्छा ठीक है, हाँ।
सर ज्वाइन कर लिए क्या पटेल सर?
पटेल सर ने ज्वाइन कर लिया है।
हाँ ज्वाइन कर लिया। Actually, Nilesh was asking that Patel sir has not joined. I said कि we'll wait ना Patel sir.
No sir has joined.
अच्छा, so Patel sir से अभी तो टाइम है 3 मिनट।
नमस्ते।
नमस्ते सर।
नमस्ते।
नमस्ते सर।
Good evening. Good evening.
We all are waiting for you, sir.
Good evening.
Yes. Good evening.
नाम सर,
अभी हमारे 3 मिनट बाकी हैं। 2 मिनट
तब तक फोन कर लेते कुछ लोगों को। मैडम
एमसी पटेल सर, गुड इवनिंग।
Good evening. Good evening.
तब तक कुछ लोगों को फोन कर लेते हैं।
सुमन मैडम, गुड इवनिंग टू ऑल।
गुड इवनिंग रोमा दी।
नमस्कार।
गुड इवनिंग। ना मैम।
नमस्ते पटेल सर।
Namaste.
Namaste, Patel sir. I'm Dr. Neelam.
हाँ जी।
प्रेसिडेंट मुजफ्फरपुर।
Anju दी has joined. She was finding difficulty in joining.
I could join.
सुबन मैडम बहुत सुंदर लग रही है।
Yeah.
रोमा तुम भी
बहुत सुंदर लग रही है।
सुमन हमेशा अच्छी लगती है।
Everyone is looking beautiful.
सुमन मैडम को बोल रहे हैं।
नीलम मैम आपकी लाइट थोड़ी एडजस्ट करिए, पीछे
हाँ।
की लाइट बंद करिए, सामने की चालू करिए।
देखो तो इसको।
आपका चेहरा डार्क दिख रहा है।
जी, एंटी लाइट थोड़ा सा इधर। हाँ।
कुछ लोगों को फोन कर ले रहे हैं जो लोग नहीं ज्वाइन किए हैं।
अपने पूरे भागलपुर एंड दरभंगा में भी बहुत लोग नहीं ज्वाइन किए हैं।
हाँ फोन कर रहे हैं।
हाँ, मगध
सर प्रणाम सर, ज्वाइन करना आपको, गेस्ट ऑफ ऑनर है जी।
नमस्ते अंजू
सर
मैडम।
अभी आपका प्रोग्राम।
अंजू मैडम
ये सुनो ना, इसको म्यूट कर।
गुड इवनिंग।
कैसे हो मैडम?
गुड इवनिंग डॉक्टर ज्योति।
कैसे हो मैडम आप?
डॉक्टर नीलम। हाय, ठीक हो, अपना बताना।
अच्छी मैडम।
यहाँ तो इतनी गर्मी है कि बस।
अंजू दी अपना वो तब तक अपना शेयर कर लीजिए स्लाइड्स को।
एक बार हम भी करके देख लेते हैं।
हाँ,
एक बार हम भी कर लेते हैं।
स्लाइड्स हम नहीं शेयर करेंगे क्योंकि मेरे लैपटॉप में प्रॉब्लम आ रहा है।
अच्छा,
हम
ज्वाइन करना है, ज्वाइन करना मैडम।
कैसे बोलोगे?
उनको भेज दिया
I
है
will share
मैडम
madam.
ज्वाइन
अच्छा
करना
अच्छा
है।
अच्छा मेल करेंगे, ठीक है।
क्योंकि हमने मोबाइल से ज्वाइन किया है।
ठीक है,
मैडम ज्वाइन करना है। मैडम ज्वाइन करना है आपको।
रेखा इज नॉट ज्वाइन लगता है।
हाँ ना,
हाँ ज्वाइन तो किए हैं।
आपको भेजिए तो पीपीटी
पीपीटी भेज दिए हैं नीलेश जी को, उधर से वो लोग शेयर
भेज दिए
करेंगे।
मैडम,
भेज चुके हैं।
भेज दिए।
हो जाएगा, कोई दिक्कत नहीं।
हाँ 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 भेजिए मैडम। हाँ भेज, देखिए, हाँ देखिए, हाँ लिंक इनको भेज नहीं मिल रहा, अभी भेज दे रहे हैं। नीलेश नीलेश कर रहा है क्या?
Yes.
नीलेश जी एक बार हमको थोड़ा सा गाइड करिए ना, थोड़ा सा गाइडेंस तो जरूरत पड़ जाता है कई बार इसको शेयर करने के लिए। जैसे एक बार हमको बता दीजिए, जूम हम पहले ये रख लिए स्लाइड सामने में।
पहले मैडम उसको फुल स्क्रीन कर लो स्लाइड को।
रुकिए एक मिनट, स्लाइड को फुल स्क्रीन कर लें। ठीक है
और
रुकिए। हाँ
फिर
कर लिए। हाँ
अल्टर टैप करके जूम में
रुकिए
जूम
रुकिए एक
का
मिनट,
विंडो
रुकिए
भेजिए।
रुकिए रुकिए एक मिनट, हम स्लाइड फुल शेयर कर लिए, उसके बाद अब क्या करें?
अल्टर टैब प्रेस करके अल्टर प्लस टैब जूम
रुकिए,
विंडो में आ जाइए।
अल्टर प्लस प्रेस, अल्टर प्लस
टैब
पहले तो कुछ और ही अल्टर
अल्टर
प्लस
टैब करके आप जूम विंडो में आ जाइए।
जूम, अच्छा ठीक है, जूम विंडो में, ठीक है।
फिर जूम में आपको नीचे शेयर स्क्रीन करके दिख रहा
नहीं
होगा।
नहीं, एक बार जूम जूम वाला तो अल्टर करने पे जूम तो नहीं आ रहा है।
अल्टर
जूम
प्लस टैब दोनों साथ में दबाइए।
अल्टर प्लस टैब, टैब रुकिए कहाँ को ढूंढने दीजिए।
टैब
अरे पहले तो कुछ और, टैब
कैप्स
किधर है?
लॉक के ऊपर, टैब हमेशा कैप्स लॉक के ऊपर।
कैप्स लॉक में नहीं, पहले कुछ और तरीके से कर रहे थे, रुको।
सिंपल जैसे हम लोग करते हैं वैसे करो कविता।
वही तो हम भी वही सोच रहे थे, अल्टर प्लस टैब ही कहाँ? हाँ अल्टर प्लस टैब ठीक कर दिया, हाँ कर लिए। हाँ अब
जूम का विंडो ओपन करो।
जूम का विंडो तो दिखेगा तो ना, कहाँ दिख रहा है? अल्टर प्लस टैब तो हमने क्लिक किया, हाँ जूम का दिखा रहा है। था अब इसको करें। हाँ
नीचे मैम शेयर स्क्रीन का ऑप्शन दिखाई दे रहा है।
तो नहीं दिख रहा है शेयर स्क्रीन का। वैसे तो पहले हम जो कर रहे थे कुछ और तरीके से कर रहे थे, हर बार प्रॉब्लम आ ही जाता है, इसलिए सोचा आज कर लेते। शेयर स्क्रीन का तो एक मिनट रुकिए, जो जूम वाला दिख रहा है आ गया, लेकिन शेयर स्क्रीन का नहीं आ रहा है। वो तो ग्रीन कलर का शेयर स्क्रीन आ जाता है ना,
हाँ
लेकिन आ नहीं रहा। प्लीज थोड़ा सा बताइए, और कहीं प्रॉब्लम हो गया है जो कि नहीं हो रहा है ये। तो पहले हम एक मिनट, मेरा तो स्लाइड सामने में ही है, ठीक है, इसको हम रख लिए। उसके बाद फिर है जूम में जाना है। जूम में एक मिनट, हाँ जूम में गए, रुकिए, जूम में तो हम है ही शायद। उसके बाद अब उसके बाद शेयर स्क्रीन वाला ऑप्शन दिख नहीं रहा नीलेश जी।
एक काम करिए मैडम, तो आप वो मुझे भेज दीजिए, मैं मेल आईडी
वो
में
तो हम भेज देंगे,
भेजता
वो तो प्रतिभा दी के पास भी वो कर लेगी, लेकिन हम एक्चुअली सीखना भी तो है। एक दो बार किए हैं, बहुत बार किए, एक दो बार नहीं बहुत बार किए हैं, लेकिन कभी कभी नहीं होता है, थोड़ा सा लगता है हर बार हम भूल ही जाते हैं, इसलिए हमको एक बार बता दीजिए। रुकिए,
शेयर स्क्रीन का नहीं दिख रहा है मैडम
अभी
आपको?
दिख नहीं रहा है, जैसे जूम में आ रहे हैं ना, ये
जूम
तो
को
है।
फुल स्क्रीन में कर दीजिए।
जूम को फुल में कर रहे हैं,
हाँ
इससे
अंगिला मैडम
तो
वेलकम।
अमन को भेजो, अमन को। ये एक मिनट, ये हम
I think
शांतना
you in
मैडम को भेज रहे
webinar.
हैं फैकल्टी लिंक, उनको नहीं मिला, अभी भेज रहे हैं, भेजे थे लेकिन नहीं मिला, एक मिनट रुकिएगा।
Start, sir. Can we start?
Oh yes, it is 6. We can start.
Yeah.
ओके
Nilesh,
morning,
we
madam.
can
यस
start.
Good morning, madam.
Good
I hope
morning.
my screen is
Good
visible.
afternoon. Good evening, not morning.
Good afternoon, madam. अरे बाप रे बाप.
हाँ,
सब
तो
लोग नींद में
गुड
आजकल रहते हैं, लगता है ना ना प्रतिभा जी, इतना सबको काम ही हो जाता है कि सब भूल जाते हैं
इतना
कहाँ कौन
बिजी
है।
रहती हो कि मॉर्निंग का से इवनिंग तक याद
अपना
ही नहीं
मैडम
रहता।
गुड इवनिंग
तो
प्रतिभा। प्रतिभा
हेलो
दीदी,
सर,
नमस्ते
नमस्ते
प्रतिभा
अब
दीदी।
हर बार ज्वाइन
हेलो।
करने के लिए शेयर करते सीखते फिर भूल जाते हैं, क्या
हाय
है मेरा
डॉक्टर
भी है।
ज्योति.
हाय
हेलो सर, एमसी पटेल सर.
Yes, namaste, welcome.
नमस्ते.
स्वागत है।
नमस्ते.
प्रणाम
so
प्रणाम।
we are
हेलो.
going to start our session now.
Oh yes, we can start.
Okay, so good evening to all respected faculties and delegates. I am Nilesh Darji in association with State Organization of Gynecologists and Obstetrician of Bihar, jointly with Bhagalpur, Darbhanga, Magad and Muzaffarpur, welcomes you in this 138th edition of Happy Learning Masterclass webinar series. The theme for today's webinar is mixed bag. So today's webinar's program director is Dr. N.C. Patel, sir. Welcome, sir. Our convener for today's webinar are Dr. Kavita Bernal and Dr. Sneha Bhuyar. I think Dr. Sneha Bhuyar, she is not present, but welcome Dr. Kavita Bernal. Our coordinator for today's session are Dr. B. Kalpana and Dr. Jyoti Banglowala. Let me introduce Dr. B. Kalpana. Dr. B. Kalpana is Post Director for Postdoctoral Fellowship in Endogynecology affiliated to MGR Medical University. She is a National Coordinator for Infertility Committee FOXY, Chairperson for Infertility Committee ENFOG, Secretary for MOGS, and holds various other positions. And she has also received many she has also been invited as a guest lecturer in many national and international conferences and have published many papers in national and international journals. Also organized many conferences and laparoscopy workshops. Madam has also received various awards from various government and universities. So welcome, ma'am. Our next coordinator is Dr. Jyoti Banglowala. Dr. Jyoti Banglowala is the secretary for IOGS. She has 26 years of experience. Her interests are in high-risk pregnancy and adolescence health. Madam has also published many papers and conducted various educational and awareness campaigns. Madam has also received various awards from MP government and Indore city. And also, Madam is an executive member of IEC and Breast Health Committee. Madam is a IMA representative for MTP Committee Indore and treasurer for IOGS 2019 and 2019 to 2020. So welcome, ma'am. Today's MOC for this webinar is Dr. Suman Sinha and Dr. Asa Jain. Dr. Suman Sinha is the president for Ranchi Obgyn Society. She is a senior consultant at AHIVF and Infertility Center Ranchi. Madam is director for Advanced Care and Maternity Center Ranchi. She is also vice president for SOVSI and member Eurogynae Committee for FOXY. She is also organizing chairperson FOXY is Zone Conference with UA 2022. Madam has also done various publications and received various awards. And Madam has interest in vaginal surgery, high-risk pregnancy, and endoscopic surgery. Our next MOC is Dr. Asa Jain. Madam has 32 years of experience, and Madam is the director for SMSA Hospital, Raipur. She is also medical director for Cancer Prevention and Relief Society. She is an elected member for CG Medical Counseling and also hold various positions. And Madam has also very vast academics and received various certification and done various training. And Madam's fields of interest are saving uterus, fetal medicine, obstetrics and gynec ultrasound, critical care, and preventive oncology and colposcopy. So welcome to Dr. Asha Jain and Dr. Suman Sinha. And before we move ahead, let's have a lamp lighting session.
Sound कम करके रखें.
Thank you so much, all respected delegates. Now I will hand over the session to Dr. Suman Sinha to take it further. Over to you, ma'am, Dr. Suman Sinha.
Thank you, everyone. Thank you, Nilesh ji. Can you hear me? Am I audible?
Yes, yes, ma'am.
Yeah, thank you. Good evening, everybody. I, Dr. Suman Sinha, President, Ranchi Society, and your MOC for today's program, take the proud privilege to welcome all the dignitaries and esteemed guests to the 130th episode of Happy Learning Masterclass webinar series in association with Darbhanga, Magad, Bhagalpur, and Muzaffarpur OB-GYN societies. Lamp lighting by our dignitaries has given a spiritual touch and blessings to our webinar. As we all know, this webinar is the brainchild of our program director, Dr. MC Patel, sir. His vision and dedication has brought us to the 130th series of this episode. He is committed to spread knowledge to the last Foxian. Once again, a very warm welcome to one and all. I invite Dr. Jyoti Banglowala to introduce Dr. Sneha Bihar. So hence he is not there. So kindly introduce Dr. MC Patel, sir, and request him for the official welcome address.
Thank you. Thank you, Sneha, madam, Suman madam. And good evening, each and every dignitaries on the dais and all the delegates who joined this 138th episode, which is knockout 138. And for this, all the respect to Dr. MC Patel, sir, who is the person behind this mammoth task. And as everyone knows and everyone says, what you dress, what you think is the reflection of your own personality. Such pure white dress, sir, reflects always sir's personality. Sir wants to actually spread the knowledge, the light of knowledge to each Foxian. And sir is actually each and every Foxian owe to the sir, very respectful person to all the Foxians. And I invite Dr. MC Patel, sir, for his word of wisdom and for the welcome address to all the dignitaries. Welcome,
Thank
sir.
you, Jyoti, for kind word. It gives me immense pleasure to welcome you all on 138th episode of Happy Learning Masterclass web series, Joining Society, Bhagalpur, Darbhanga, Magad, and Muzaffarpur. I welcome Dr. Rangila Sinha Madam. She has kindly consented to be chief guest to bless us. Of course, Rangila Madam is always with us for any of our academic activity. Welcome, Madam, for sparing time. Thanks for the same. I also welcome two guest of honor, Dr. Bharat Prasad sir from Darbhanga. He is also very kind to me and he is always with me in any of my academic activity. Welcome, sir. I also welcome Dr. S. Roy Mitra Madam from Bhagalpur. She is also with us in any of our academic activity. I also welcome two learned speakers, Dr. Anju Turiyar Madam from Bhagalpur and Dr. Kumundini Jha Madam from Darbhanga. They are going to discuss very respective topics for today's webinar. I also welcome two learned moderators, Dr. Pratibha Singh from Bhagalpur She is chairperson of International Academic Exchange Committee. I have seen her working since long in Foxy. I also welcome one more moderator, Dr. Kavita Barnwal from Bhagalpur, and I put it on record that she has helped me a lot as far as this very webinar is concerned. She is a person behind this webinar, not only for execution, but from designing to inviting faculty. So I put it on record. It's my deep sense of gratitude
Thank you so
to
much.
Dr. Kavita Madam. You have helped me a lot. So welcome. I also welcome all the learned expert panelists who are going to put their expert comments during panel. Dr. Sneha Buyar, she will join a little late. Dr. Rekha Rajendra Kumar from Bengaluru and Dr. Bharti Rajshekhar from Hassan. I also welcome all the learned panelists who have joined this webinar. Dr. Rasri Puri Madam, Dr. Leena Nair Madam, Dr. Vibha Verma Madam, Dr. Santwana Kumari Madam, Dr. Reena Singh Madam, Dr. Rasi Sinha Madam, Dr. Sunita Sharma Madam, Dr. Sadhna Sinha Madam. I also welcome all the chairperson who have kindly consented to chair respective session. Dr. Prachi Singh Madam, Dr. Pallavi Roy Madam, Dr. Archana Jha Madam, Dr. Rekha Jha Madam, Dr. Neelam Sinha Madam, Dr. Roma Yadava Madam, Dr. Maya Shankar Thakur Sir, Dr. Ramdar Tiwari Sir, and Dr. Lata Shukla Madam. So I welcome all the learned faculty. I also welcome to convener Kavita Barnwal again and Dr. Sneha Buyar. They are convener for this series, and Sneha Buyar is since long in this series. I also welcome two coordinators, Dr. B. Kalpana from Madurai and Dr. Jyoti Banglowala from Indore. They both are with me in this series since long. Both are very hardworking lady. So welcome Dr. Kalpana and Dr. Jyoti Banglowala. I also welcome two Master of Ceremony, Asha Jain from Raipur and Dr. Suman Sinha from Ranchi. They both are also with us in this series since long.
Thank you.
And I welcome all the president and secretary of respective society who have joined this webinar. There is Bhagalpur, Darbhanga, Magad, and Muzaffarpur, and all the delegates who have joined this webinar. In era of COVID-19, where physical meetings were not possible, we four friends started this series, and our aim was to meet our Foxian friend on virtual ground to say hello, to discuss focus topic, and share knowledge. And ultimate goal was to be helpful to our patient. And with this aim, we started this series, and we have continued this series because by 2030, we have been given a goal by WHO and national government that maternal mortality should be less than 67 and infant mortality should be less than 12. And it could be only achieved by joint efforts on part of government, on part of NGOs, on part of federation like IMA and Foxy, and particularly our obstetrician friend who are working in remote area. Because even today, there are few states in southern India, they are having maternal mortality less than 30. But at the same time, there are few states having maternal mortality near 200. Say, for example, Assam. Bihar, UP is not doing well as far as maternal mortality is concerned. So with this aim, we had started this series, and on with love and affection of all the delegates who join every Tuesday with this series. They encourage us, they inspire us to continue this series, and we are with you again for this webinar to discuss focus topic. So welcoming you all. Thank you very much.
Thank you, sir, for your blessings and pearls of wisdom. Now I take the opportunity to invite and welcome our second convener, Dr. Kavita Barnwal, for being very helpful in making of this program. So can I have Dr. Kavita CV? Nileshji, yeah. Kavita is a very, very good friend of mine. She's very hardworking, and presently she is secretary of Bhagalpur Obstetric and Gynec Society. She is a laparoscopic surgeon in her own Samarpan Hospital at Munger. She is also honorary teacher at Lord Buddha Koshi Medical College and Hospital. She is member of YTP committee, and we are really happy to inform you all that she is the person to bring this YTP Champion Award to Bhagalpur Society, and also Dr. D.K. Tank Award to Bhagalpur Society. There are many accolades to her, and my best wishes are always with her. So, Dr. Kavita, once again, thank you and a very warm welcome to you. And I invite you to introduce and welcome our chief guest, Honorable Dr. Rangila Sena, Madam.
Thank you, Suman Madam. Thank you for kind words and wishes. So please share CV of Rangila Madam. Though Rangila Madam is well known to all of us. So Honorable Chief Guest Rangila Madam, Professor Rangila Madam, Guest of Honor, Dr. Esra Mitra Madam, Dr. Bharat Sir, Master of Happy Learning Program, MC Patel Sir, who is always ready to help small society members like us. Coordinators of this webinar, conveners, and Jyoti Bangla, my good friend, B. Kalpana, one of other good friends, and coordinators, Dr. Asha Jan Madam and Suman Sinha Madam. So I think Rangila Madam is well known, but just I want to say learning and growing together is a powerful way to build strong relationships and create a healthy and productive environment. This type of environment promotes collaboration, mutual trust, and respect among all its members. It also encourages creativity, innovation, and problem solving. So with these words, I welcome Rangila Madam, who is well known. She is founder president of not only Muzaffarpur Society, but also All Bihar and Jharkhand Society. She was professor and head of the department at Muzaffarpur Medical College. She has served Muzaffarpur Society as well as Foxy in various ways, and her special area of interest is gynecological ultrasonography, safe motherhood, and eclampsia. She was Vice President Foxy between 1992 and 93, Chairperson Public Awareness Committee of Foxy between 1993 and 98. She has presented many papers and chairs sessions in many national as well as international conferences, and she has also organized Safe Motherhood Seminar of AOFOG in 1994 in Muzaffarpur, which Professor S.S. Ratnam, past President FIGO, and Professor S. Arul Kumaran, past President FIGO, had participated. So with these words, and I wish Rangila Madam a very long, healthy, happy life. She is like our guardian, always guides us, always speaks good words about us, and always blesses us. So she has also written a book, a gynecologist born in, I don't know. So it has been removed. So with these words, I invite with great honor Rangila Madam to say a few words. Rangila Madam.
Thank you very much. Am I audible?
Yes, madam. Yes.
Yes, madam.
Thank you very much, Dr.
Kavita
Banwal, for nice words. I always agree with Dr. Patel. Dr. Patel is doing very nice work. He is, I am always with you that this webinar is much better than what used to be seen, because you can involve more and more people and more unapproachable from unapproachable places. So nobody, even at my age, I'm not feeling tired in joining these webinars. I always like, because it is so comfortable. Be sitting in your house and meeting all your colleagues, listening them as long as you want. So this is your idea is very good, and I think that this is one it was a gift from Corona, because previously we never thought webinar, but once Corona gave us this opportunity, and we are organizing these conferences, these webinars. Actually, what I wanted to, all these subjects, all these topics you have chosen is very well chosen and very informative. It will be interesting to everybody and informative. But today I want to emphasize more about this awareness regarding prevention of cancer cells. Now that well established vaccine of cancer vaccine is in our hand. It is very important. It is very important that each and every gynecologist and obstetrician should make it a point that whosoever woman, whenever you are coming across with any woman, you always inform her that there is a vaccine. You know, actually, I myself was not very much convinced that there will be a vaccine. Once it came in market, I heard, I read, but then I was not so much convinced that I will very firmly convince my patients. And that now after some times, after seeing this effect of this vaccine, I think it is the best preventive method in your hand, which you can use. And you always try to use it in meeting women groups like Inner Wheel, Rotary, and approach all women that they should bring their skull childs and inform them in detail. When you will convince them, they will have much more they will realize the importance of. They are hearing from media, they are hearing in the newspaper, but they will be not so much convinced. Then treating obstetrician and gynecologists emphasize it with example, and you can organize so many programs also to, as I told you, that go in meeting of Inner Wheels and Rotary and then Lioness, and they are convinced them that now there is one vaccine which can prevent cancer. So this is important, I think, and I have actually printed so many pamphlets from this trust in the name of my husband, Dr. J.P. Singh. And among that different pamphlets, I'm going to introduce now this cancer vaccine. And that is given free of cost, distributing anybody, everybody who wants. So this is one thing which I want to emphasize about prevention. And other methods of prevention, screening, it is going on, it will go on. But today I want to emphasize. My principle is that teach what you know. Always try to teach what you know. Even it's very smallest information you are getting. That I have started from very early of my teaching period. Whatever you know, what you know, you always teach. And always try to learn from teaching others. That is a dissemination of knowledge. It's important part of human duty and as a duty of gynecologist. And also I emphasize that always one don't work only for patients and for your profession, but keep always your health also in your important work, important aspects of your everyday activity, and that will make you more and more useful to your society. Longer you will be active, longer you will be useful for your family, for your society, for your nation. These words I want to thank all of you, and I wish that this webinar should continue. Don't stop. Always keep it. Thank you very much.
Thank you, madam, for sparing time to bless us and your word of wisdom. You, of course, you are always with us and you are source of inspiration for so many of us to continue this type of activity. Thank you, madam.
Thank you, Rangila madam, for your blessings. As sir has said, your words are really an inspiration
I
for
will
us.
hear whole seminar, whole webinar I will hear.
Thank you, madam. It will be our great pleasure if you are here with us. So next, I invite Dr. Kalpana to introduce our guest of honor, Dr. Bharat Prasad sir, and ask him to bless the webinar.
Thank you, Dr. Suman. It is my to be a part of this wonderful Happy Learning Masterclass series that 38th edition in association with the great Federation Bigar Society organized by MC Patel sir, who is working hard to reach 138th edition and also ready to help each and every gynecologist who is a medical legal expert, assisted by Kavita ma'am, who had taken so much effort to organize this webinar. It is my pleasure to introduce and invite Bharat Prasad sir, who is a, can we have the slide, profile slide? Do we have his profile? Can you please?
Yes, ma'am, already shared.
No, only images are there. His profile is.
You haven't shared.
Okay.
It's slide 17.
Once again, ma'am, I am sharing just.
It is always our pleasure to get the blessings of our senior. As Madam told, dissemination of knowledge is the great task. Even IMC sir is doing the same thing, reaching 138th episode. Almost every Tuesday, all gynecologists are listening to this Happy Learning series. It is my pleasure to invite and introduce Bharat Prasad sir, who was a past visiting professor, Sims, Bharatpur, Nepal, former professor, and also now associated with Santosh Medical College, Saraswati Institute of Medical Science, Hapur. Sir has been teaching and has been an examiner for UG and PG in various examinations. Also, the beauty is here we have many founder, president and secretaries in this webinar. We know how hard they must have worked to start a society from their efforts. It's really, we are blessed to have you here as an motivation. Sir was the founder secretary and president of founder secretary and present president of Darbhanga OG Society, organized 5th annual conference AOGS BJ 2012. Sir was vice president to chaired many scientific sessions, presented many papers. Sir, your blessing is really important for us, for your words of wisdom, sir.
Welcome, sir. Bharat sir.
Yes.
Yes, welcome, sir.
First of all, my pranam to Dr. Professor Rangila Sinha, Dr. S.C. Rai Mitra, and good evening to Dr. M.C. Patel, and blessing with love to my junior colleague and students. Now I am telling Dr. M.C. Patel, I am very thankful to you that you have given me opportunity to become a part of this very important and wonderful webinar. You are the master of organizing webinar. You are organizing webinar at frequent interval, and uh, you are the master, and you know how to organize. I am very much thankful to you. This is the way in which you are organizing the webinar. It is very important. You are organizing the webinar in that manner that no society of the Foxy will divide from this participating this type of webinar. You will in near future, in the course of time, each and every society of the Foxy will be included in your seminar. I think so. And I am also this is also very important to select the topics of the different types of the presentation. It is very difficult because you are arranging the webinar at frequent interval so many times. So important topics and brilliant topics and recent topic selection is very difficult. You are selecting very nicely and you are doing very well. And I am also thankful to you again for this invitation to me to become a part of this webinar. Thank you very much, Dr. M.C. Patel. Thank you.
Thank you, Bharat sir, for kind words and a word of appreciation. Just for your knowledge and knowledge of all the delegates, we have already completed 2 rounds of all the Society of Foxy. This is our 3rd round, and this 3rd round also we are going to complete within 2 months. So then after it will be our 4th round. So till now we have included all the society, irrespective of strength of the society or category of the society, whether category A, category B or category C. And goal is to reach all the Foxian who are unreached. So this is our goal, to reach them, to meet them, to say hello to them, and to discuss focus topic through this webinar platform. Thank you, sir, for kind words.
Thank you, Bharat sir, for your words of wisdom. And now I take the opportunity to invite Dr. Asa Jain to introduce our guest of honor, Dr. Santwana Rai, Madam, and take her blessings.
Namaskar, Mehul ji. So,
please for the CV of Madam. Yes.
It is my pleasure. Namaskar from Dr. Asha Jain to all the presenting faculty. And it is my pleasure to introduce Dr. Santwana Roy Mitra. She is an MBBS in 1965, about the time we were born, from Patna Medical College. She is the patron Bhagalpur Gynec Society, past president of Bhagalpur Society. She has practiced as a distinguished gynecologist for about 46 years at Bhagalpur after taking over her father's practice. In the process, she has gathered rich and varied experience in the field. She has also taken up many other activities like joining Foxy, opening the Foxy Associated Society, and she has received an award for Safe Motherhood Program. She's organized cancer detection camps, conducted medical exhibition at Bhagalpur, felicitated by Dr. Malhotra, then president of Foxy India. On retirement from active practice, she has conducted a large number of medical camps in the rural areas, and she is presently residing in Kolkata and spending time enhancing knowledge in the field of medical science in general and gynecology in particular. So welcome, madam, and we look forward to your blessings to this webinar.
Thank you. Thank you very much. I don't want to repeat.
Yes, madam, do bless us, madam.
Only blessings. Always, I must cooperate with all the folks and with this meeting, and my blessings is always there. Thank you.
Thank you, madam,
Thank you
for
so
sparing
much,
time
ma'am.
to
Thank you,
bless
madam.
us. Yes, your words for blessings are enough for us to bless us and to inspire us for this type of activity. Thank you, madam.
Hey, thank you.
Thank you, Santona madam, for your blessings. And now with this, we come to the end of our program. And for this, I'm really thankful to our chief guest, Dr. Rangila Sinha madam, our guest of honor, Dr. Bharat Prasad sir, and our guest of honor, Dr. Santona Roy madam, and all the faculties and the delegates who have joined us today for gracing this occasion. And now we begin the academic session. And I hand over my charge to Dr. Asa Jain to take over the first session. So over
Thank
to
you,
you,
Dr.
Natasha.
Suman. Thanks a lot. And may I have the CVs of the chairpersons of the first session, please? So our first session is going to be PRP in gynecology. And may I have the CVs, please? No, of the chairpersons. Dr. Prachi Singh, she's an MBBS DG or DNB FICOG. She's a consultant at Ashirwad IVF Center. She has started the first IVF center of North Bihar in 2013. She is the recipient of Young Gynec Award at first conference of AOGSBG, and she has presented numerous papers and has publications. Next, please welcome Dr. Prachi. Dr. Pallavi Roy, madam, she is an MS from Patna Medical College, and she is honored by FICMCH and FICOG, has more than 20 publications in national and international journals, has more than 26 years of teaching experience, has presented many papers, chaired many sessions, has been a national member of the Safe Motherhood Committee, and has organized several camps in rural areas for public awareness. She is the immediate past president of Muzaffarpur Obstetric Gynec Society, and her field of interest is medical disorders in pregnancy. Welcome, Pallavi Roy, madam. Our third chairperson is Dr. Archana Jha. She is a life member of IMA, IMS, ISAP, IAG, SOVC, fellow of AMS, IMA, past honorary secretary, Vogs, Bhagalpur, past vice president, IMA, Bhagalpur. She's been an external examiner, participated as speaker, chairperson, moderator, and panelist in several state and national conferences. And her special interest is in social work, contraception, high-risk pregnancy, infertility, and midlife management. Welcome, Dr. Archana Jha. And I request one of the chairpersons to introduce the speaker, Dr. Anju Turier.
Good evening, all. It's my prime privilege to introduce today's speaker, Dr. Anju Turyar, our past president. She is MBBS DG of Obstetrics and she is director of Matritva Clinic and ACMO Begusarai, Bihar State Coordinator for SNLP, and she is a Zonal Coordinator IH and ex-member of Breast Committee, ex-member of CMP Committee, and she has participated as faculty in various international and national conferences, and she is a very versatile speaker and social worker. It is my privilege to chair this session on the new topic, platelet plasma and its role in different aspects. Anjudi, please start your speech.
Yes, Anju, I am Dr. Pallavi Rai. Anju, your topic is platelet-rich plasma, which is very new, and researches are going on it. But some centers are using this, and this is used for male and to improve the result of infertility treatment in male and female both, as ovarian rejuvenation, increasing the thickness of the endometrium, and in male to increase the sperm mortality. Detail about this topic, platelet-rich plasma, Dr. Anju will discuss. Dr. Anju, please.
Thank you, Pallavi and Archana, for your kind words. I'm very happy to hear from you, and I should thank all the organizers, and especially Dr. MC Patel sir, for including me in this webinar. This masterclass series is a big hit, the webinars. My pranam to Rangila Di, Bharat sir, Kumudni Di, Santwana ma'am, and I'm sorry if I forget some name, Pallavi Di, and I'm from there, Dr. Ramadhar Tiwari. I need your blessings, all of you, to bless you for everything. And my greetings from Andhra Pradesh to all. And I like seeing my friends' faces. I thank Kavita, Suman, Dr. B. Kalpana Naidu also for including me in this webinar. Now coming to my topic, today I'm going to speak about PRP therapy in gynecological disorders. Yes, slide is being shared, yes. Now PRP and its applications. PRP is a cellular component. Next slide. PRP is a cellular component of plasma derived from the whole blood. The voice is echoing. PRP is a cellular component of plasma derived from the whole blood, containing a higher plasma concentration. The cellular content of plasma is normally composed of 93% RBCs, 6% platelets, and 1% WBC. But in case of PRP, basically it's a reversal of this ratio, containing 93% platelets, 6% RBCs, and 1% WBC. In recent years, doctors have learned that the body has the ability to heal itself. Hence, the concept of PRP and stem cells are surfacing. As a result of explosion of technologies in the modern age, regenerative medicine encompassing PRP and stem cell therapy has been erratically emerging treatment choice of the last decade. Now, difference between, I'll skip this slide. PRP, next slide. Yeah, PRP was first introduced in 1970s to describe the autologous preparations and enrichment of plasma concentration. The primary role of platelets in its contribution to homeostasis and addition, leading to platelet activation and aggregation. It has also been found to play a role in regulating inflammation, angiogenesis, stem cell migration, and self-proliferation. The theory underlying this treatment modality was derived from natural healing process, as the body's first response to tissue damage is to deliver platelets to the injured area. Platelets promote healing and attract stem cells to the injury site. Now coming to clinical practice, PRP injections have been applied to diseased ligaments, tendons, joints, and also in hair growth and transplant with superb outcomes in terms of repair. PRP is superior to growth factor because platelet activation leads to a release of multiple growth factors and differentiation factors. PRP contains vascular endothelial growth factor, transforming growth factor, platelet-derived growth factor, and epithelial growth factor. These factors aid in migration, attachment, proliferation, and differentiation of cells, and promote accumulation of extracellular matrix. These are various types of PRP. That is, first is the vascular endothelial growth factor, which is responsible for growth and new generation of vascular endothelial cells. Next is transforming growth factor, which is responsible for growth and neogenesis of epithelial cells and vascular endothelial cells. promoting of wound healing. The cytokines like IL-1, 6, and 4 help in healing of muscle injury and transdifferentiation of fibroblasts into myofibroblasts. Now, the hepatic growth factor is an angiogenesis stimulator. The epithelial growth factor helps in promotion of epithelial cell growth, angiogenesis, promotion of wound healing. The fibroblast growth factor helps in tissue repair, cell growth, collagen production, hyaluronic acid production. Now, the insulin-like growth factor, it regulates the normal physiology in all cell types and improves the early healing of tendon defects. Last but not the least is the platelet-derived growth factor. This helps in cell growth, new generation, and repair of blood vessels, collagen production. Next slide, please. This is a preparation of PRP. I don't think we should go in detail. That is 30 to 60 ml of blood is drawn from the arm, and that gives us about 3 to 6 ml of PRP. Next slide, please. Next. Next. Because these are all the process of preparing. Yeah. This autologous PRP is derived from individuals' whole blood and then centrifuged at double centrifugation to remove the RBCs. The remaining plasma has 5 to 10 folds higher concentration of growth factors than the whole blood. Next, PRP composition and activation. Platelets contain high concentration of cytokines and growth factors stored within alpha granules. The growth factors include platelet, we've already spoken about this. Platelets also contain fibronectin, vitronectin, and sphingosine 1-phosphate that initiate wound healing. Platelet activation triggers the release of growth factors by a variety of substances or stimuli such as thrombin, calcium chloride, and collagen. No evidence is available regarding ideal concentration of the activator required to trigger optimal release of growth factors during activation process of PRP. This is the deeper classification of PRP preparations, and we should not go into the detail of this. We come to mechanism of action, which is not completely known. Lab studies show that high concentration of growth factors in PRP can speed up the healing process. Growth factors promote wound healing by initiating the following stages, that is tissue necrosis resolution, chemotaxis, cell regeneration, cell proliferation and migration, extracellular matrix synthesis, remodeling, angiogenesis, and epithelialization. PRP is superior to recombinant human growth factor as platelet activation leads to release of multiple growth factors and differentiation factors. Please mute others. Smile request to please mute others because there's a lot of going on difference. Now applications of PRP in cervical ectopy. Hua and all conducted RCTs to compare effectiveness of autologous PRP application to laser treatment for benign cervical ectopy. PRP was applied twice on area of cervical erosion with 1 week interval in 60 patients, and laser treatment was used in other 60 patients. The cure rate was 93.7% in PRP group and 92.4% in the laser group. The time to re-epithelialization was also shorter in PRP group. The rate of adverse effects, that is the vaginal discharge or bleeding, was again lower in PRP group than in laser group. Hence, autologous PRP application appeared promising for treatment of cervical ectopy in symptomatic women. In case of vulvar dystrophy, PRP has been tried in autoimmune conditions not responsive to corticosteroids, for example, lichen sclerosis and eczema. LS also causes progressive pruritus, dyspareunia, and genital bleeding. It also causes extensive scarring of vulva and progressive loss of labia minora, sealing of clitoral hood, and burying of clitoris. Application of PRP in cases of LS resistant to steroid therapy in 28 patients by injecting PRP into vulva in a fanning pattern. The patients received 3 PRP treatments about 4 to 6 weeks apart and again at 12 months. Nearly all patients exhibited clinical improvements in the lesion size, and in 28.6% of patients, lesions disappeared completely after PRP treatment. There was minimal pain and no complications were reported. Hence, PRP injections could be considered effective for LS therapy. Next, PRP in skin lesion and wound healing. I'm sorry, there are some spelling mistakes which I was not able to correct. This is not own but wound. PRP has been tried in many dermatological conditions and autoimmune conditions not responding to corticosteroids. It's also used in other skin lesions and wound healing, that is in operative cases, and also in musculoskeletal diseases. The stages are again said, which we had discussed earlier: tissue necrosis resolution, chemotaxis, cell generation, regeneration, cell proliferation and migration, extracellular matrix synthesis, remodeling, angiogenesis, and epithelialization. Due to its ability to promote angiogenesis, wound healing, it is frequently used in dermatology for variable conditions, for example, treatment of ulcers, scars, even alopecia. It is also used in high-risk pregnancy LSCS, which causes great reduction in redness, edema, ecchymosis, and discharge from the wound site. Approximation score of wound was about 85.5% versus 72% in the control group. Same was seen in gynec surgery. Autologous platelet grafts applied effective for the pain reduction and with no associated adverse effects. Next, PRP is becoming a more popular as a non-operative treatment option for broad spectrum of medical disorders. It is widely used in ortho and sport medicine to alleviate pain by the natural promotion of healing musculoskeletal diseases, for example, tendonitis, arthritis, ligament sprains, and tears. In other words, PRP injections have been used for athletic injuries, resulting in exceptional healing, rapid return to regular activities, and complete relief. This has been established. Next, please. Now, PRP is reconstructive surgery for vulvar cancer. Morelli and al. Conducted retrospective study of patients who underwent surgery for vulvar cancer, that is a radical vulvectomy. The aim was to evaluate efficacy of platelet gel application in women after radical surgery. The patients were divided into 2 groups. In group A had 10 patients which had platelet gel placed on vaginal bleach during reconstructive surgery. In the group B of 15 patients underwent only surgical treatment. Now the results are as follows. There was lower rates of wound infection, necrosis of vaginal wounds, and wound breakdown in group A. Same was in reduction of post-operative fever rate, shorter hospital stay, and fast wound healing in group A. So we conclude that platelet gel application before vulvar reconstruction proved effective for preventing wound breakdown after surgery to treat locally advanced vulvar cancer. Now, PRP in urogenital disorders. PRP in genital fistulae. A small fistulae could be treated conservatively with PRP, and the success rate was about 67 to 100%. PRP has also been tried in treatment of BPF as a novel, minimally invasive approach for closure of genital fistulae. PRP was injected around the fistula into the tissues, and platelet-rich fibrin glue was interpositioned in the tract. Many fistulae got closed in a follow-up after 6 months. The evidences are Shrivan and all injected PRP around fistula into tissue, platelet-rich fibrin glue was interposed. Following cases for 6 months, 11 were cured with normal findings on TBS, physical examination, and cystography. This concluded that autologous PRP injections and PRF glue interposition is safe and effective. Gardini and all presented case of complicated iatrogenic low rectovaginal fistulae treated by interposition of buccal mucosa and apposition of PRP. Gottens also performed PRP injections into fistula tract and mucosal advancement in mucosal advancement flap in 10 patients with Crohn's disease related high perianal fistulae. The healing of fistula in 70% cases was seen after 1 year. One patient experienced recurrence, and 2 patients' fistula persisted after treatment. So we can conclude that this procedure was moderately successful in Crohn's disease fistulae, and the success rate was 70%. The PRP in genital prolapse and urinary incontinence. PRP restores the anatomy and function of pelvic ligaments, especially advocating its use to urinary incontinence resulting from damage to pubo-urethral ligament. But PRF is a mixture of platelets, leukocytes, cytokines, and circulating stem cells, optimal for stimulating fibroblast migration and proliferation, and causes rapid remodeling and connective tissue growth after vaginal surgery. Grillo and all, Mendel and all, and Nicolopoulos and all, they have tried several studies, but mostly in vitro. Galero conducted an observational study of 10 consecutive women requiring surgery for prolapse recurrence, stage 2 or higher, with 80% success rate and complete symptom relief. The sexual activity increased by 20% without dyspareunia. Mendel and all reported that attachment of fibroblast to vaginal meshes increased after coating meshes with PRP in vitro. Nicolopoulos and all reported use of PRP in urinary incontinence resulting from damage to pubo-urethral ligament. The conclusion is PRP helps regulate tissue reconstruction and restoration of pubo-urethral ligament strength, but studies did not provide sufficient evidence to justify its use. PRP in reproductive medicine. This is very important nowadays. In case PRP in premature ovarian failure. Now it's called insufficiency. POF or POI is the loss of non-ovarian function before the age of 40 and hence accompanied by infertility. The researchers injected murine ovaries with growth factors and mature eggs and appeared to develop from ovarian stem cells. The introduction of isolated growth factor bearing platelets directly into ovaries triggers resurgence of oocyte production. Treatment with PRP in ovarian rejuvenation. PRP is injected into the ovary directly under ultrasound guidance, similar to what we do in oval IVF. Pantos and all at Israel in 2016 introduced ovarian rejuvenation. They injected PRP in 8 perimenopausal women or women with POF. There was successful ovarian rejuvenation after 1 to 3 months after PRP treatment. All cases underwent natural IVF cycles with follicles of 15.20 mm, resulting oocytes were inseminated with ICSI, and all resulting embryos were cryopreserved. In case of ovarian torsion also, it has a role. But this is only in rats. This was seen in rats, not yet tried in humans. 60 adult rats were subjected to ischemia and bilateral adnexal torsion for 3 hours. Intraperitoneal PRP was administered 30 minutes prior to ischemia in one group. The detorsion was done and oxidative stress levels, histopathological changes, and reperfusion injuries were known in the PRP group. So we conclude that PRP was effective in the rats. PRP in refractory endometrium. This is being used nowadays in most of the IVF or infertility clinics. The endometrial growth following inadequate ovarian stimulation may lead to poor results of IVF or exercises. The various stages are suggested to improve endometrial thickness, especially in resistant cases. PRP is again a novel therapy for this. Colombo and all included 8 patients who underwent PRP treatment. After PRP application, endometrial thickness was satisfactory in 7 cases. Positive test for HCG was found in 6 women. So multiple implantation failure was by inefficient expression of additional molecule, which could be improved by PRP application. In case of refractory endometrium, Zadaha modaris and all included 10 patients who had a history of cancelled cycles due to inadequate endometrial growth that is less than 7 mm thickness. The endometrial thickness increased at 48 hours after first PRP application and reached to more than 7 mm after second PRP application in all patients. Embryo transfer was carried out in all patients. 5 patients became pregnant, that is 50%, and in 4 of them, pregnancy progressed normally. Hence, PRP was definitely effective in endometrial growth in patients with thin endometrium. In case of repeated implantation failure, also usually it is due to, usually not always, due to thin endometrium. The intrauterine infusion of PRP may promote endometrial growth and receptivity. Nazari and all enrolled 20 participants with history of recurrent repeated implantation failure to evaluate effectiveness of PRP in improved pregnancy rate. 18 out of 20 participants became pregnant. That is 90% achievement was done. 16 clinical pregnancies were recorded, and other pregnancies were ongoing. So the conclusion is PRP was effective in improving pregnancy outcomes in repeated implantation failure. Now the use of PRP in aesthetic gynecology. Next slide, please. PRP is used in breast reconstruction and also in female sexual dysfunction. That is the O-shot therapy and vaginal rejuvenation. Platelets have been found to release around 35 growth factors that promote tissue regrowth, healing, and regeneration. In accordance to this property, it has been successfully utilized by aesthetic gynecologists in treatments such as vaginal rejuvenation and O-shot therapy. PRP used in sexual dysfunction is considered to be a revolutionary new non-surgical OPD treatment that improves both urinary incontinence and sexual dysfunction by using the woman's own growth factors. Now we come to the method. It is injection of PRP into specific areas of vagina with the help of local anesthetic cream. This modality of treatment is called post-shot. PRP immediately activates tissue regeneration and with dramatic enhancement in sexual response, including improved arousal, stronger orgasm, decreased dyspareunia, and increased natural lubrication. We come to vaginal rejuvenation. In this, after PRP injection, vaginal vascularity is increased with subsequent increase in sensitivity. The skin becomes thicker and firmer, making it look more youthful. Even the ligaments and muscles supporting the urethra become stronger, alleviating urinary incontinence as well. Another application of autologous lipofilling mixed with PRP in case of vaginal atrophy produced relief from symptoms and continued restoration. This rejuvenated appearance of the external genitalia provided a pleasing cosmetic outcome for the patient. Next. PRP in premature rupture of membranes.
Dr. Anju?
Yes.
Please, ma'am, it's a 20-minute lecture. Please try to wind up fast.
Oh, okay.
All right. We've been half an hour already, so please wind up.
3 slides are left. Okay. PRO occurs due to damage and tears in fetal membrane. In this case, PRP plug was applied to it. The plug was stable and attached firmly to the amniote tear for 2 months. So it also provided waterproofing sealing of iatrogenic defects in amnion inferior. Hence, PRP stimulates cell growth, proliferation, and enhances membrane healing response. Now we come to the conclusion. PRP is an innovative therapy modality, affordable because it's just an OPD procedure. It doesn't require any special setup like stem cell therapy. It is simple, easily performed, autologous, and effective. It is non-invasive. It is non-invasive with promising results and no side effects. The risk of PRP therapy as infection, bleeding, and nerve damage is minimal. Yet, large number of RCTs are required to confirm efficacy and safety of PRP in various OBS and gynecological disorders. Thank you for a patient hearing. Next slide, please.
Thank you, Anju madam. That was an
I request all the secretaries and presidents of all societies to support and nominate us, because most of the delegates and faculties are going for the election of chairperson. So my best wishes to all of them and request to all the secretaries and presidents to nominate and support us. Thank you. Thanks for the patient sharing.
Thank you. Thank you, Anju madam, for that exhaustive and very informative slide. We know now that PRP is used in so many indications actually, because it helps in wound healing. So whenever the body is injured, the PRP will help. I personally have experience with thin endometrium, and I would like to share that one patient, she had severe endometrial damage due to tuberculosis, and she did not have any withdrawal bleeding with estrogen and progesterone. And after doing hysteroscopic adhesiolysis, I gave her PRP for 2 to 3 months. And then after that, she started having periods, and then estrogen was given. Ultimately, IVF was done, and she delivered a live male baby at 43 years of age. So that was the PRP really helps in wherever especially in infertility cases where the endometrium is damaged.
Yeah,
so thank you. Thank you. And I think we'll take the questions at the end of the session.
Sure.
Yeah, so thank you, Dr. Anju Turiya, madam. And
Thank
I thank Dr. Patel, sir, for inviting me to be chairperson in this very prestigious CME. Thank you.
Thank you, Patel sir, and all organizers for giving me this opportunity to chair this important session. And the newer modalities we should accept and we should try. More trial is needed to implement in day-to-day practice. Our experts are there to use. So thank you, Anjudi. It was very good. Thank you. Thanks to all.
Asha Madam, over to you.
Thank you.
Yeah, but yes.
Yes, so now thanks a lot for this first session. And now we are going to start the second session. And I request Dr. Kalpana to introduce the chairpersons of the second session.
Thank you, Asha ma'am. So the second topic is again an interesting topic, pain management in endometriosis. We have n number of drugs available in the market. So how do we choose that? I request all the chairpersons, Dr. Rekha ma'am, who is a dynamic president of Bhagalpur OG Society. Madam is also E-Zone coordinator of PAC Committee for XZ, organizing chairperson of 9th AOGSJ, scientific chairperson IMA Bhagalpur, secretary IMA Bhagalpur 2003. She was the secretary of Bhagalpur, a life member of IMS, RCH coordinator, life member of Red Cross too. Worked with the Lions Rotary Society and also Anti-Corruption Bureau. Welcome, ma'am. Our next chairperson is Neelam Sinha, ma'am, who is the president of Muzaffarpur OG Society, senior obstetrician and gynecologist, working in Sinha Nursing Home, Juran Chapra. Madam has been trained in laparoscopic surgery, past gynecologist in Sadar Hospital and also SKMCH Muzaffarpur, past professor of RDM Medical College, Turkey, Muzaffarpur. Madam was a clinical secretary of MOGS, past vice president of MOGS, and life member of IMA. Attended many conferences.
Ma'am, please 2-3 lines and fast.
Yes.
Please.
Yes, ma'am. Welcome, Neelam, ma'am. Yeah, because our society is also named as MOGS, we have an affinity towards MOGS. Welcome, ma'am. Our next chairperson is Dr. Roma Yadav, ma'am, who is a consultant gynecologist, Siddharth Memorial Maternity Center, Bhagalpur, Vice President of Bhagalpur OG Society and member of MTP Committee for FOGSI and Chairperson MTP Committee, Bhagalpur. Welcome, ma'am. Over to you, Chairpersons.
Thank you. Thank you very much, Dr. Kalpana, for introducing all the chairpersons. And I would like to invite the speaker, Dr. Leena Nair. Can you, Dr. Kumudni Jha, sorry. Dr. Kumudni Jha, madam. So Kumudni Jha, madam, is a senior to me, and she is a very knowledgeable person, MD, PhD, DNB, and she has had many publications. More than the publications, she has got a lot of students, and all the students really love her because she's an excellent extempore teacher. She has been teaching for many years in Darbhanga, and she's retired. And she has conducted so many seminars. She has presented several papers and has been examiner for a long. And welcome, Kumudni madam. You know that I really truly love you, and I'm really honored to be a chairperson in your session. So kindly over to Dr. Kumudni Jha, madam. You are all set to start your deliberation, madam. Kumudni, the internet is, I think, weak. So Can you hear me? Can you hear me?
Your voice breaking, ma'am. I think
Internet is not of proper strength, and so kindly can you send the slides to somebody else who can share it, and then you can speak. Okay. Now this one is good. This is good. Okay. Hello, can you hear me? Hello, can you hear me?
Yes, ma'am, now.
Hello. You can do one thing. You can you hear exit me? from the other device. You can exit from one Hello. device. Yes, we can hear you. Hello. Am I audible? Yes, you are audible. Yes. And is my screen visible now? Your screen is visible, but your slide sharing has not started.
You
we
can't
can see
hear
your,
me?
we can see your face, not your slides.
Hello, Kavita.
मैडम यहाँ जी मैडम आप स्लाइड्स नहीं आप चला पा रहे हैं ना तो आप
Whom
भेज
can I
दीजिए
send my presentation to? Whom can I send the presentation to? Please, can you send me the email?
Yes, you can send on WhatsApp or on mail to me or Kavita. You can do it.
रेखा मैडम को भेज दीजिए मैडम रेखा मैडम को भेज दीजिए
I will share it then.
हाँ
if it takes time, shall we move on to the third session so that
Hello.
if the slides are ready, we can come back for the second.
कविता हाँ किसको ईमेल का एड्रेस जरा कर दो ना तो उसको भेज देते हैं
आप रेखा मैडम को व्हाट्सएप करिए रेखा मैडम
मेरे मेल एड्रेस पे भी भेज सकती हैं आप
व्हाट्सएप में ले लीजिए जल्दी मेल पे ले लें
wherever she sends I will do it.
तो WhatsApp कर
Just needs to send it, then only I can do it. No.
Kumudini ma'am, will that okay?
Yes, Dr. Kalpana, you can carry on with the session, and when she is ready, then we will tell you.
Yeah. We will move on to the
With
next.
the permission of Dr. MC Patel, sir, you can move on.
MC sir.
Yes. We can save time. No issue.
Yes. Do we have Jyoti Banglawala? Jyoti?
Yes, Kalpana.
Take over.
Okay. So with the permission of MC Patel, sir, we are moving to the session 3, the legal issues in management of endometriosis. For that, we are having our esteemed chairperson, Dr. Maya Shankar Thakur, sir. He is the secretary Darbhanga Obs-Gynae Society, and he studied MD Gynae in Ops at Darbhanga Medical College. We welcome you, sir. Our next chairperson is Dr. Ramadhar Tiwari. Sir is ex-associate professor in Gaya and ex-professor and HOD of DMSCH. And at present, he was the founder president of Magad Society Gaya, ex-president IMA Gaya, ex-vice president IMA Bihar, and ex-secretary BHSA MMCH Gaya. And at present, he is president of Magad Obs-Gynae Society. We welcome you, Tiwari sir. Our third chairperson is Dr. Lata Shukla Dwivedi ma'am. She is professor and head of the Department of Obs-Gynae in ANMM Medical College, Gaya, Bihar. And she is master trainer in CAC, EMOC, BMOC, an examiner for UG and PGs, an executive member in POGS and coordinator of Wonder APP program. She has gained the MS Signature Award in 2022, and she is having many publications in many international and national journals. We welcome you, Lata ma'am. I request Dr. Maya Shankar Thakur sir to introduce our esteemed speaker, Dr. MC Patel sir. And please play the MC Patel sir's. And I request Dr. Tiwari sir to say a few words about this topic. And I request Dr. Lata Shukla Dwivedi madam to conclude that topic. I am handing over mic to Maya Shankar Thakur sir. Sir, Thakur sir, are you there? Ramadhar Tiwari sir, you can give introduction.
Okay, good evening.
Ji sir. Good evening, sir. Good evening.
Welcome from the
Sir,
but
please
he is
bit loud.
consultant
Yes.
physician, gynecologist, and medical legal counselor, vice president, Foxy 2018. Chairperson, Ethics and Medical Legal Committee, Foxy 2011 to 13. Honorary Secretary, State Organization of the Gynecologist and Obstetrician, Organizing Chairpersons, MMCON, Honorary Member, National Inspection and Monitoring Committee, PNDT Act, Government of India. Then Vice President, Foxy 2018, and President, Ahmedabad OBGY Society, Honorary Member, National Managing Body, Indian Red Cross Society, Headquarter, National President, National Medical Organization 2016 and 18, and President IMA Ahmedabad Branch 2007 and 8, Honorary Surgeon, Indian Red Cross Eye Bank, collected more than 1,000 eye pairs. And above all, he is actually the master trainer, and he has already said that this is the third round all over India. So actually he is the master trainer, and we are really obliged by hearing Dr. MC Patel. MC Patel, sir.
Thank you, Ramadhar sir, for kind word. Any chairperson have opening remarks, or should I start?
You can start your deliberation, sir.
हम तो रख लिए, सब हम कर लिए, तब हम वो सब नहीं, वो हमको मत बताओ, मतलब हम को होस्ट रहेंगे तब ना हम कर पाएंगे, हम को होस्ट नहीं है। हाँ 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 ठीक।
Okay, sir.
Yes. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of respective society for joining this webinar. Medico-legal challenges in management of endometriosis. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and we gynecologists rank first as far as medical legal consequences are concerned. Because in our day-to-day practice, we take utmost care of our patient, but we never know. Accident may happen at any time. And once accident happens, then it becomes a potential case as far as litigation is concerned. So face the litigation and pay the compensation, because which are the areas for litigation in management of endometriosis? First is diagnosis. Many a times delayed in diagnosis or investigation or treatment, missed diagnosis, investigation or treatment, and wrong diagnosis. So these are the areas as far as treatment of endometriosis is concerned, and this could be the allegation on part of prosecution when we are facing litigation. Complications related to treatment of endometriosis is also one more area. Say, for example, if we go with medical treatment, then side effects of medicine could be one more area as far as litigation is concerned. And as far as surgical treatment part is concerned, can surgical management of endometriosis be considered as a fertility enhancing surgery? Very important question asked, because in any case of infertility, usually few of our friends have a habit to straightway advise diagnostic laparoscopy. It's fine, but they will explain to the patient that this surgery is fertility enhancing surgery. And as far as treatment of endometriosis is concerned, surgical treatment, they will advise patient that if we go with surgical treatment, it will enhance the chance of fertility. And many a times this is misrepresentation, and many a times in court of law it becomes very difficult to prove in this type of situation when case is raised or question is raised on part of prosecution. As far as surgical treatment part is concerned, unexpected result or failure of procedure or operation, trauma, injury, hemorrhage, infections, complications of anesthesia. These are the areas for litigation in this type of surgery. Injury to surrounding structure during endometriosis and laparoscopic surgery or laparotomy, whichever the way one goes, but there are possibility of injury to surrounding structure, to the vessels, ureter, urinary bladder, and bowel. And once it happens, then it becomes a potential case for litigation. So let us see one case. It was a case of severe dysmenorrhea, and she had infertility also. It was deep-seated endometrial nodule on sigmoid column. So on diagnosis, it was confirmed that it is deep-seated endometrial nodule on sigmoid column, and laparoscopic excision was advised. So during laparoscopic surgery, injury to sigmoid colon happened, and ultimately it ended into colostomy. And second surgery to close colostomy, and again anesthesia and anastomosis. So the second surgery was done. So in this particular case was filed, and compensation demanded 11 crores. Of course, it was not passed by court, but compensation allowed was 42 lakhs in this particular case. So where things went wrong? So in this type of situation where injuries occur, it becomes a potential case for litigation. So at the time of counseling in this type of case is very much important. If you have counseled everything that it is at sigmoid colon, it is deep-seated, I will try to remove it without injuring sigmoid colon, but there are few possibilities that sigmoid colon may get injury, and we may have to pass through all this process of colostomy and second time surgery, etc. And if you have counsel, if you have taken consent in that way, then it becomes a good defense in our favor. One more area is recurrence. And we know, as far as treatment of endometriosis is concerned, endometriosis is very notorious disease. And one cannot give any kind of guarantee as far as treatment is concerned and full recovery is concerned. So if at all recurrence happens, then again it becomes a area for litigation. So in this type of situation, if we have counsel patient that recurrence is known in endometriosis, in spite of all care and caution and treatment, so we are saved in court of law. Some miscellaneous issues are also involved in the treatment of endometriosis. And one very common allegation is unnecessary investigation, because to come to conclusion, to come to diagnosis, we have to go for so many investigation in this type of situation. No proper consent. So just I mentioned that proper consent is very much required. So it should be well observed. Staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer. If at all you have to transfer patient to higher center in an emergency, then many times this could be the allegation that it was delayed in transfer. Complications, just I mentioned prior also. Morbidity, because in this type of situation of any case of endometriosis, it is all likely that patient may end up into morbidity, and it becomes a potential area for litigation. In few of the cases, mortality. So these are the areas as far as litigation is concerned in the time of treatment of endometriosis. Overcharging, tremendous expense against unexpected result is one more area for litigation. Ask for medical record, and if you have not provided. So once any patient asks for any medical record of treatment given, you are under obligation to provide within 72 hours as per standard guideline from MCI and with guideline of NMC, now newer version of MCI. Within 5 working days, you have to submit all the medical records of treatment given to the patient. Failure of patient to comply with the schedule follow-up. Many times, if you have advised patient for follow-up and patient fails to come to follow it, but if you can prove it, it becomes a good defense in your favor. Because if at all patient doesn't follow your instruction, then it becomes contributory negligence on part of patient and it becomes a good defense. So what to do and how to prevent not to end up into litigation during treatment of endometriosis? Because in court of law, whenever you are facing litigation, this very question is asked, was it preventable? So during treatment of endometriosis, any damage suffered by patient, very important questions come that was it preventable, and usually you cannot say no. So if it is yes, then what did you do to prevent it? So all the measures you took to prevent any complication, you will have to prove by your record. And many times, in spite of for your care and caution, you cannot prevent certain complication. Then one more question will be asked, why you couldn't prevent it? And one more very important thing, if at all some complications happen, say for example, injury to surrounding structure at the time of surgery of endometriosis. So did you diagnose in time? Because many times very minute bowel injury may go unnoticed. And after few times, patient come with distension of abdomen or some other problem. And it may be troublesome for us to explain to the patient. So very important questions come that did you diagnose that complication well in time? And very important question you will have to answer. Did you manage way in which any prudent doctor would have managed? If at all any injury occurs during treatment, and if you diagnose well in time, and if you manage way in which any prudent doctor would have managed, then you could be out of problem as far as prosecution part is concerned. So practice foreseeability, that is anticipation, good communication and valid consent, and proper documentation, and you will be simply sail through. So court and law expect us or expect from us foreseeability or to anticipate certain complications, required procedure, required intensive care at the time of managing endometriosis. If we are dealing with surgical management, then we should anticipate all the probable complications and we should counsel patient. And not only to anticipate, but we should be readily available to deal with the situation. And if you can prove all this, then you could be out of problem. So proper counseling is very much required. Whatever you are going to deal with, patient should have full knowledge with all its benefits and all its side effects. And it is very obvious. More is the time you spend with the patient in consulting room, less is the possibility you needing to spend time with that patient or relative of the patient in court room. So communication is the key to avoid litigation. And it is very obvious. We might have the best medicine in the world, but it won't be successful if patient doesn't understand. So as far as counseling is concerned, usually in any of our OPD, we start like this. What is the complaint? And there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So at the time of counseling, we are under obligation to explain about all the alternative modalities of treatment. Which are the modalities of treatment as far as endometriosis is concerned? Medical method, surgical method. So we have to explain all the alternatives to the patient. Possibility of morbidity also we have to explain. Probable expense, possibility of mortality in a few of the cases, and probable prognosis. All the complications, related complications, remote or late, we should explain to the patient not to end up into any kind of confusion or litigation in future. Possibility of blood transfusion, if at all you have planned to go for blood transfusion. Risk involved, whichever the risks are involved in treatment of endometriosis, we have to explain all the risk involved. And whatever we explain, it should be in a very simple language, no much medical jargon. And it is very obvious, no rosy picture about result, no tall claim about result as far as treatment of endometriosis is concerned. Because we know we cannot give any type of guarantee as far as treatment of endometriosis concerned, because recurrence is known, we all know. So in eye of law, when you claim to be master, then you are supposed to be master. So no tall claim, no rosy picture, because in our practice, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture. So proper communication and proper documentation is a secret of success. And whenever you get signed consent paper, because consent paper is not mere piece of paper, but whatever you have counseled, whatever you have communicated, and you have entered everything in that consent paper, then it becomes a documentation of your communication. And in this very famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient has to sign, but it is a very important document of your counseling, of your communication. So whatever you have counseled, whatever you have communicated to the patient related to your treatment plan should be well entered in consent paper, and patient should sign that document. And once patient signs that document, it becomes documentation of your communication. And when you offer all those record in court of law, it becomes a communication of your documentation. So it is very obvious, but records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. And it should be easily acceptable whenever offered in the court. And you should have all the facility to deal with the situation. Whenever you are dealing with a case of endometriosis, and particularly surgically, and particularly in deep-seated endometriosis nodule on sigmoid colon or anywhere else on bowel or any other area, then you should have all the facility to deal with all the probable complications which you may encounter during course of treatment. One should be experienced one. Otherwise, you can involve your professional colleague in dealing with the situation accordingly, or you can refer patient to appropriate center. But in all this situation, prior consent is very must. One more area, there can be a common consent also, diagnostic as well as operative procedure together. Say for example, many times we have advised only diagnostic laparoscopy in case of infertility, and we see some patches of endometriosis. And if prior consent is not taken, then you cannot go for fulguration of endometriosis patches. So in this type of situation, prior consent to deal with situation accordingly should be taken. So there can be common consent for diagnostic as well as operative procedure together, and a particular surgical procedure and additional or further procedure. So you can go with consent for both at a time, but you should explain everything to the patient. Consent given for specific treatment, you cannot do other procedure unless it is life-saving. Just I mentioned, if you have a case of infertility and if you have gone for diagnostic laparoscopy, you cannot go for operative part as far as endometriosis patch is concerned. And your argument in court like this, it was beneficial, would save time, would save pain and suffering in future, doesn't stand in court of law. So whenever you counsel, whenever you take consent, you should enter everything in consent paper. So where we stand as far as treatment of endometriosis is concerned, and it is very nicely said by William Osler that medicine is a science of uncertainty and art of probability. And it is again saying by Charles that problem with world is that intelligent people are full of doubts while the stupid ones are full of confidence. And this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many provisions in law also in our favor as far as medical practice is concerned. But if we do not know all those provisions, then they won't be helpful to us. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. A small slip can make a big trouble. So an ounce of prevention is worth more than a ton of cure. Rightly said in Panch Tantra. So all the best. God bless you. Have a litigation-free medical practice. With regards, salute to all who have joined this webinar. all the societies and president and secretary of respective society. Thank you very much.
Thank you, sir.
Please ask if
Thank
time
you, sir.
and chairpersons permit. Thank you very much.
Thank you, sir. Next.
The remarks of other chairpersons, please.
Our Tiwari sir can also conclude with remark, no issue.
Yes.
Nothing to conclude because everything he has told. The problem is that the consent is very important. Records are very important. But the literacy rate of our society or our place is very much low. So they don't understand very much. And the attendant who already they are counseled, when something happens, the other people will come and they start doing all sorts of misbehavior. So they are the problems. But one thing is very important, that counseling must be done, record must be prepared, and that is a good defense.
Yes.
So this is very important.
Rightly mentioned by you, sir. So as far as counseling and consent is concerned, let me share. Now on Foxy website, uniform consents are available. We three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consents. Say, for example, cesarean section, for hysterectomy, abdominal, vaginal, endoscopy, and endoscopy surgery. We have also separate consent for anesthesia, separate consent for blood transfusion. So almost 30 different consents are available on Foxy website. You have to simply visit, download, and use in your day-to-day practice. Everything taken care during precising, preparing those consent. And as per famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008, what should be the ideal consent? Which are the criteria for any consent to be valid in Indian context? So taking care of all those points, we have prepared all those consent. You can download it and you can utilize. But one request, it is in English. So anybody translate in Hindi, I will be more happiest person and I will be helpful to also. So anybody starts doing that, it is always welcome step. Thank you very much, sir.
Okay. Thank you, sir. Thank you.
So Kalpana, you can start now.
Yeah. Thank you, sir, for the wonderful lecture, because endometriosis is known for its progression and recurrence. So counseling and consent plays an important role when we go for a surgery in endometriosis patient. Thank you, sir, for your views and guidance as far as endometriosis is concerned. So now I think chairpersons have been introduced. Kumudini ma'am is ready with the presentation. I request ma'am to start your presentation, pain management in endometriosis.
Thank you so much, Kalpana ma'am. Am I audible?
Yes, ma'am, you're audible.
Thank you so much. Very good evening to everybody, and my humble pranams to and sincere regards to Dr. Rangila Sinha, the founder of AOSBJ, and Dr. MC Patel, Dr. Neelam, the president of MOGS, and Dr. Amadar Tiwari, and our ex-president, Dr. Bharat Prasad. My warm regards to all of you. And thank you so much. My sincere gratitudes to Dr. Rekha and Dr. Kavita for inviting me on this platform. This topic of pain in endometriosis is a very important topic, and I'm going to talk about it. But then before starting the actual the treatment of pain, we must know a little bit about the diagnosis, the pathogenesis, and the etiology. Next slide, please. So by definition, endometriosis is an enigmatic disease of inflammatory origin in which the endometrial cells are found outside the endometrial cavity, leading to pain and infertility. But we have so many theories because we don't actually know the real cause behind it.
And that is why we started first with the Sampson's theory, which was theory of retrograde, spillage of the menstrual blood into the peritoneal cavity. Then came the theory of coelomic metaplasia, because that could not explain the extra pelvic endometriosis, like in the lungs or the scar endometriosis. Now then, after that came the immunological theory, where it was found that the pro-inflammatory cytokines and the NK cells, they were high, seemed to be high in patients of endometriosis. And that is why they lead to inflammation. The other theory that came up was the theory of inflammation and the genetic theory, the immunomodulation theory. Then came the theory in which they found that the angiogenic factors like the VEGF, that was found to be high in the peritoneal deposits in patients of endometriosis. And lastly, now it is all boiling down to genetics. So we see that we have so many theories, and accordingly we have so many treatments. So the prevalence is found to be around 10% in the general population, but it is much higher than that because it is underreported in adolescents. Prevalence of infertility in endometriosis is around 50%, and the prevalence of infertile patients in patients of endometriosis is around 25 to 50%. The prevalence of pain is 54% in patients with endometriosis. Next slide, please. Next slide, please. So who are the people in which you should suspect this and think of managing their pain? Pain may be there in many conditions, but in those patients who have these high-risk factors, like a patient, an adolescent with early menarche, or a patient of PCOS, if she's complaining of severe dysmenorrhea, then we should have endometriosis as a differential diagnosis for pain. Family history, if the mother, the sister, or the aunt had similar episodes of dysmenorrhea, then we should consider endometriosis in that patient. Mullerian abnormalities, how does this affect? Supposing you have a patient of cryptomenorrhea. Now there is a collection of blood in the vagina, the hemotocorpus, then in the uterus, and that spills into the peritoneal cavity. There's retrograde flow if the obstruction is not released. So that may lead to endometriosis. Now, infertility. We all know that endometriosis is a very, very important and common cause of infertility. By the toxic content that is present, the fluid itself is toxic to the sperms. It prevents its motility. Even if there is an embryo implantation, its effect on the endometriosis may lead to repeated implantation failures. Then the motility of the tubes, the anatomy, and is all distorted. And of course, if there are endometriomas, we all know that it leads to reduced ovarian reserve. Patients who are obese, then previous surgeries that haven't been done. And hysterectomy, we used to do that earlier when we didn't have misoprostol in patients who wanted MTP in cases of, say, 18, 20 week size. So in those cases, we used to do hysterectomy, but it went into disrepute because of the incidence of endometriosis that happened in these patients. So we used to take special precautions to pack up the cavity, change the gloves after the baby was taken out, and then don't use the same material, that suture material you've used for stitching the uterus. You don't use that for the peritoneum or the skin or the subcutaneous tissue. So because that led to the deposits of endometriosis. Then pelvic pain. Now this can masquerade as chronic pelvic pain or even as an interstitial cystitis. If the patient is complaining of repeated failures of treatment despite your analgesics that you're giving, then you must consider, even in patients of cystitis, there may be a cause. The cause may be because of endometriosis, or in chronic pelvic pain, or patients presenting even with backache only. Then thyroid issues and neonates with withdrawal bleed. We all know that the neonates, the female neonates delivered after that, many of the mothers complain that the patient has had vaginal bleeding after 2 or 3 days. So we explain to them that it is because of estrogen withdrawal. But there is this theory of stem cell implantation, which says that those babies who have had this vaginal bleed in the neonatal period, they are candidates for future endometriosis. Next slide, please. Next slide, please. Yeah, so the symptoms, dysmenorrhea, and that is the secondary congestive type of dysmenorrhea, which occurs in 60 to 80% of patients because of the collection of blood during menstruation and there being no outlet So it causes a tension in the cyst, and that leads to dysmenorrhea. Chronic pelvic pain, that happens in 40 to 50% of patients. And that is one of the causes for absenteeism. That is one of the causes for the lack of economy and the absenteeism from work. Then dyspareunia. This happens in 40 to 50% of patients. Now, when you do a PVA examination, you may find a nodule in the pouch of Douglas. Infertility, we've already seen how it causes infertility in these patients. And irregular menstruation may occur in 10 to 25 or 20% of patients. Dysgeusia, the patient may present only with dysgeusia or with diarrhea, which is not responding to common treatment. Dysuria and hematuria. There may be cyclical hematuria. There was a patient who had melena, which was found, the patient, there was no lesion except for one nodule in the rectum, and that was found on biopsy to be a case of endometriosis. Hematuria will be cyclical in these patients, and for differential diagnosis, you have to have another differential diagnosis in which there is cyclical hematuria, that is in the patient of VVF, in which the VVF is above the internal os. Next slide, please. So to come to a diagnosis, the clinical suspicion should be very high. There should be a high index of suspicion, and especially when you have these patients with high-risk symptoms. The mainstay of the treatment, the diagnosis was usually thought to be laparoscopy, but now we all know that the non-invasive TVS is one of the most important and informative modalities of diagnosis. When you do a TVS, it is very close to the pouch of Douglas. So even DIE, that is disseminated deep infiltration into the pouch of Douglas or into the rectum, may be even diagnosed by TVS, by the sliding sign, which if it is positive, it moves in opposite directions if it is free. But if it is moving in the same direction, the gut is moving in the same direction as the uterus, then there are adhesions. So MRI is generally not the first line of investigation, but that is required when you have a doubt that it is infiltrating into the rectum, into the colon, or into the bladder, because that has an advantage that you can arrange for a urosurgeon or a gastrosurgeon while opening the abdomen, so that if need, they can help you. Laparoscopy, that was the gold standard long time back, but now it is recommended that laparoscopy should be done only once in a lifetime for a patient of endometriosis, and that should be the final treatment. Non-invasive markers are now being looked for, like biomarkers, like the microRNA. Now, there are very exciting new developments in this field. 2,606 numbered microRNAs have been found, and 109 of them have been seen to be present in the saliva. Now, they are also looking at it that you number these microRNAs, and if you find, say, 10 to 20 numbers are present in patients with peritoneal endometriosis, or say 40 to 60 numbers are present in, they are present in patients with infertility. So if you have this gradation and classification, you don't need to opt for surgery in all patients. So that will be a big advancement. And in genetics also, it has been seen that in monochorionic female twins, there are loci which are present, genes which are present on these loci, which are not present in those females who do not have endometriosis. Then molecular transcription, that is a big network, and they are being targeted, and so are the single nuclear polymorphism and the exomes. They are forming packages of exomes, which can replace the ones which cause endometriosis. Next slide, please. So management and decision-making for an unknown cause. We do not know the exact cause, so we have many options. Like we all know that it is a estrogen-dependent tumor disease. So hormones are being used as a first line of treatment. The COCs were being used. But now you know that it is estrogen-dependent, so we do not want to give COCs with a high content of estrogen. So you go for the low-dose pills. And it is the letrozole in those resistant to COCs that may be used. The mechanism is that it is an anti-aromatase inhibitor, that is an aromatase enzyme inhibitor. You know that DHA is present in the stroma, and that goes into the granulosa cells where it is converted into estrogen. And here the rate limiting step is the aromatase enzyme, which is inhibited by letrozole. Then endometriosis causes infertility by reduced ovarian reserve or tubal motility and distorting its anatomy. The fluid is considered toxic to the sperm motility and leads to repeated implantation failures. Hence, salpingectomy or clipping is done in these patients. Then, because there is an increase in the VEGF levels, so that is why we use VEGF inhibitors like cabergoline. The environmental hormonal disruptors are also held responsible for altering the hormonal milieu. DPS and these things are alleged, they are commonly used even in simple things like children's toys, your lipsticks, whatever you're using synthetic has these things, and they are responsible for disrupting your hormonal milieu. Exomes against the SNPs that we've already discussed are also being explored. Now, immunological theory, because of that, we know that there are pro-inflammatory cytokines like cytokine 1, 6, and 8, and they are elevated. The Treg cells and the NK cells are also involved. Hence, you have anti-cytokines that have been developed now and anti-NK factors. Because it is basically an inflammatory process, we use NSAIDs as the first line of treatment because they act against the prostaglandins. The transcriptors like TGF-beta can be targeted. And now even the macrophages are we have two types of macrophages, 1 and macrophage 2. One is for scavenging and the other one is for repairing and healing. And these lead to fibrosis. And they are now being trained to prevent fibrosis. This is another exciting field for research now, which is going on. Artificial intelligence is, of course, coming up in a big way. So genomics, proteomics, and epigenes are all being targeted for the treatment of endometriosis to prevent the inflammatory lesions. Next slide, please. So what are the drugs that we have? Apart from that we already discussed, GnRH analogs like neferalin and goserelin, they downregulate the pituitary and hence reduce the FSH-LH, and that reduces the estrogen level. But at the same time, the side effects we all know that leads to a low VMD, and hence an advec therapy is a must. But here, because we don't want estrogens to further proliferate them, so we can use progesterone also. But whatever COCs you use as a backup should be of the low estrogen containing pills. Progesterone causes deserialization and atrophy, inhibits the metalloproteins, and thereby reduces inflammation. There are many types of progesterones that are being used. The medroxyprogesterone acetate. Digesterone is now coming up in a big way for this. Norethisterone is used, and LNG is used in IUDs. Dynogest has affinity for progesterone receptors only, and not for the estrogen or the androgen receptors, and not for the mineralocorticoid receptors. Hence, it is considered an ideal progesterone for long-term continuous use, and it has been used even up to 5 years without many side effects. The dosage of MTA is usually 30 milligrams daily, Dynogest 2 milligrams daily, and norethisterone 5 to 10 milligrams daily. Dynogest reduces the lesions in adolescents, and it is also used to prevent recurrences post-op. After operative procedures, there are incidences of recurrences, and it is around the tune of about 20 to 25%. So we do need to give a progesterone to reduce this recurrence. Dihydrogesterone is a retroprogesterone with an immunomodulatory effect that is converting the Th1 to Th2 types from the pro-inflammatory to the anti-inflammatory type by suppressing the IL-1, 6, and 8. It increases the nitric oxide levels and hence has an anti-inflammatory effect. Next slide, please. So you can see here the different effects of different progesterones and why we should be selective about it. Norethindrone, ethinyl diacetate, norgestrel. So you can see they have estrogenic effects also, as well as progesteronic, and norgestrel has even higher androgenic effects. Norethinol, and you have to give a long-term use, so you cannot be giving any random progesterone. Levonorgestrel, you can see it has progestational and androgenic effects to a great extent. So it cannot be used for a long time. Then in the third generation, again, you have norgestimate and desogestrel, which has progesterone as a reduced amount of androgenic activity. Drospiridone has plus minus progesterone effect, but Dinoges, which we are using now commonly, that has only progestational effects. It has no estrogenic or androgenic or mineralocorticoid receptor effects. Next slide, please. So we can also use GnR antagonists. These are injectables. The advantages is that it has no flare effect like GnH agonists, and it causes less hypoestrogenism, and hence no reduction in PMD, and therefore there's usually no need for an ADPAC therapy. And now in the recent past, the elagolix and rilagolix, all this has come as an oral form of GnRH antagonists. They are expensive, but they are available now, and it can be given in a dose of 150 milligrams per day, or if higher doses are required, even 200 milligrams can be given. Aromatase inhibitors, they are the second line drug for endometriosis associated pelvic pain. They prevent conversion of steroid precursors to estrogens. The anastrozole, letrozole are third generation aromatase inhibitors, and when used with progestins, can significantly reduce the endometriosis associated pelvic pain. They reduce the lesions and improve the quality of life. The side effect of a long-term use of these is that it may lead to drawback is that there is a lot of ovarian follicular cysts that form. And NSAIDs, they are antiprostaglandins and hence reduce the interleukins and cytokine associated pain. Next slide, please. So now the other group is there, which are called SERMs, tamoxifen, raloxifene, and bazidoxifene. They have anti-proliferative effects and reduce the endometriotic implants in a dose of 10 milligrams per kg. Ulipristal is a good SERM. It was out of the market because it was considered that it has some severe side effects on the liver, and even some cases of liver transplant had come up. But now, if you are giving it, you have to monitor the liver function test every month, and after 3 months, you can give a break. So mifepristone in a dose of 25 milligrams is used, and that acts as an anti-proliferation agent without causing hypoestrogenism, and they also reduce the blood loss. But the risk with them is that it may lead to vascular thromboembolism. And when you use raloxifene, there may be hot flushes also. LNG-IUS is a very good option for those who need prolonged use because you don't have to pop in pills every day. And it contains 52 milligrams of LNG. It releases 20 micrograms per day, and the efficacy is at par with GnRH analogs. When the study was done comparing these two, it was found to be at par. Estrogen receptor ligands like oxabicycloheptane sulfonate and chloridazole are in the trial phase at present. The anti-angiogenic drugs that we've talked about is capromorelin, and endostatins, Angenex, rupamycin, doxycycline, PPARN, and rosiglitazone. They prevent progression, recurrence, and normalize the cycles. A study was done in AIMS where they gave capromorelin, which blocks the VEGF receptors and reduces the size of endometriomas. They gave a dose of 0.5 milligrams twice weekly for 3 months. Then they gave a break for 3 months. And when the size was reduced, again, they started it for 3 months. Rapamycin statins, the TNF alpha blockers, resveratrol, tricyclic antidepressants, and neurotropic drugs also needed because these patients have a low self-esteem and they are depressed. Next slide, please. So there are alternative treatment medicines also like yoga, meditation, Chinese herbs, acupuncture, and neuromodulators. They put in chips in the abdomen, and they control modulate the pain. So there is reflexology, behavioral therapy, psychological treatment is needed in many, and may have a role in endometriosis. Surgical only when medical treatment fails. The patient does not respond to the medical treatments when the pain is acute. There are acute surgical events, or there are concomitant gynecological conditions, and the patient really needs pain relief, and there are fertility issues. Only in those cases, or where the endometriomas are more than 5 centimeters, or they are suspicious of malignancy. It is rare, but it can happen. Next slide, please. So the World Endometriosis Research Foundation and the World Endometriosis Society and WHO are all prioritizing research and policy in areas like training macrophages to prevent fibrosis, use of artificial intelligence in genomics and proteomics. World Health Organization stresses on avoiding stigmatization. Once centralization has occurred, then it is very difficult to bring down the patient from it. Early diagnosis is very important, and for that, we all need to be sensitized ourselves. We should be aware of this, and we should spread the awareness in the teenagers in schools so that they know when they're having this problem, and so they can go in for early treatment and prevent the side effects, the complications which may lead to infertility later on. Early referral is important. If you are not a laparoscopic surgeon, do not fumble with it by doing a laparotomy. Non-invasive biomarkers are again going to be the recent the things that are going to come up for diagnosis, and the skill development and awareness programs are a must. Next slide, please. So the take-home message is that before central sensitization occurs, we have to treat the patient, because once it occurs, it is very difficult to treat and pull the patient out of it. The goals of medical management are suppress estrogen, reduce retrograde spill, overcome progesterone resistance by letrozole, reduce the inflammation by NSAIDs, suppress aromatase by letrozole, and anti-angiogenic factors can be used, immunomodulators and pain modulators. Thank you all so much for a patient hearing, and I thank you, Rekha, for running my slides. Thank you so much.
Thank you, Kumud.
Yeah, yes, ma'am.
Though you had to talk on pain management, you first gave the overview, so that like a very good teacher, we got the whole revision of the endometriosis, and finally you summed up with the pain management. So the other chairpersons. Yeah.
Thank you, Rekha, for this time.
Thank you, Kumudni ma'am, for your brilliant presentation. Always you are speaking with new things, and we are learning a lot from your side. This is the fact that in endometriosis, we are coming across two problems with endometriosis, that is pain and infertility. And among all some problems are there which can't be alleviated, that is like pain. Pain is always persisting with endometriosis. And it hampers our day-to-day life, our quality of life, and even the young adolescent girl can't study, from the is always thinking about when the date of menstruation comes, always thinking about this, if there will be very distressing dysmenorrhea, and always a vague chronic pelvic pain. This all leads hampers our day-to-day life. So pain management is really a very necessitating feature for the treatment of endometriosis in association with it, as well as the treatment of infertility. You can there are so many things you can treat for the infertility, but for the day-to-day life, pain management is very much essential. And this we all know, this NSAID, letrozole, anastrozole, Dynogest. We are treating our patients with Dynogest, with cabergoline, that is all these things. But you have said about the macrophages, training of the macrophages. That is a wonderful upcoming thing in recent futures. And I think this will help a lot in the management of pain. And as the inflammation is the main cause behind the pain, this training of the macrophages will be a wonderful thing. I must.
The microRNAs, they are being used from the saliva, even in diagnosis of hepatocellular carcinoma, and BRCA1 and 2, that has been used for a long time, that has been detected in the saliva itself. So this will be a very important non-invasive step, if it is, especially if it is classified, so that we know which patients need surgery and which patients don't, like you have in the endometriosis fertility index, which tells you whether surgery is needed or not, depending on the age of the patient, the duration of infertility, and whether there's any previous pregnancy or not. Higher the scores for this, better is the chance of spontaneous pregnancy and less amount of surgery.
As Dr. M.C. Patel told, there are so many litigations and legal problems regarding the so we must think of
Can't hear you.
Roma madam, I think your internet connection is unstable. We are not able to hear you.
I'm not audible.
You can just
No,
switch
your
off
voice
your
is
video.
interrupted.
You can switch off your video, then it will be audible. Okay.
Am I audible now?
Yes, yes,
Yeah,
yes.
yeah.
Yeah, something happened wrong. So, ma'am, such a wonderful presentation, and we are in our day-to-day life. This NSAID, letrozole, anastrozole, Dymogest is also a very good drug, and also at the same time this cabergoline also, and this LNG IUS is also very good for the treatment of pain. Thank you, Patel sir, and the organizers for giving me the opportunity. And before concluding, I would like to pay my regards to all my seniors, Dr. M.C. Patel sir, Dr. S. Mitra madam, Dr. S. Mitra madam, Dr. Suman Sinha madam, and all the seniors, Dr. Bharat Prasad, Dr. Amadhar Tiwari, Rekha madam, and all. Thank you very much for giving me the opportunity.
Thank you, ma'am. Thank you. We will be taking all the question in the end. And shall we move to the fourth session? Suman ma'am. So we are moving to the session 4, the panel discussion. The panel discussion on the cancer cervix. It is the case-based discussion. For this, our learned moderators are Dr. Pratibha Singh madam and Dr. Kavita Barenwal madam. Dr. Please show the CV of Pratibha madam. Dr. Pratibha Singh madam is the consultant laparoscopic gynecologist and IVF specialist, and she is Director Healing Touch Hospital in Bhagalpur. She is chairperson International Academic Exchange Committee FOXI at present in 22 to 25, and she was chairperson Fertility and Aging Committee IMS in 23 to 24, and she is the president of Bhagalpur Menopause Society and vice president of AOGSBG. She did diploma in advanced gynecology laparoscopy.
Thank you, Dr. Jyoti. Thank you so much.
So thankful, Didi. Our next chairperson, next moderator is Dr.
I have been introduced,
madam.
Jyoti. I have been introduced, so leave it. And now we should move on because already we are late.
Okay.
Many persons are leaving the webinar.
Okay. For this session, our expert comments are from Dr. Sneha Bhuyar, Dr. Rekha Rajendra Kumar, and Dr. Bharti Rajshekar. But I think all three are not there. So we are moving to the panel.
Sneha madam is there, na? Sneha madam?
No, Sneha madam.
No, I think she's not there.
So our panelists are today. Our panelists are. Please show the serial. Our panelists are Dr. Rajeshri Purbe madam. She is APD MCH. Dr. Rajeshri Purbe madam is the PhD early detection and compared to the VILI to the pap smear. She is assistant professor DMCJ Lahiri Sarai, and she is the life member of FOXI and life member of IMA. And she is having 11 years of teaching experience in UG and PG. Our next panelist is Dr. Leena Nair Lal madam. She is consultant obstetrician and gynecologist in Lal Clinic, Bhagalpur. She is past secretary of Bhagalpur Obsgynae Society and treasurer of Bhagalpur Obsgynae Society, Bhagalpur Menopause Society, Sovsi, Bihar, and Jharkhand. And she is the invited faculty in many national and state conferences. Our third panelist is Dr. Vibha Verma madam. She is MBBS DNB PMCH from Patna, gynecologist in SKMCH, and vice president of MOGS vice president of Muzaffar Obsgynae Society, treasurer of IMA Muzaffarpur, and president of Rotary Lichvi Muzaffarpur, and secretary of Cancer Awareness Society in Muzaffarpur. Our next panelist is Dr. Sanfana Kumari madam. She is MBBS DMCH from Darbhanga and MD Obsgynae from RIMS Ranchi. She is ex-resident of NMCH Sasara, and at present she is working as SMO at SDH Nogachia, and member of Bhagalpur Obs-Gynae Society, member of ISOPAB, member of Bhagalpur Menopausal Society, and she is awarded many awards and participated as panelist on various topics at CME and webinars, and special interest is management of high-risk pregnancy. Our next panelist is Dr. Reena Kumari ma'am. She is associate professor in Department of Obs-Gynae in ANMMCH Gaya, Bihar. She is the clinical secretary of Magad Obs-Gynae Society Gaya and scientific chairperson of 10th AOGSBG in 2016 conducted at Gaya. And she has written many articles in national and international journals. Life member of IMA, ISAR and IFS, and consultant gynecologist of Shivam Nursing Home. Our next panelist is Dr. Rashi Sinha ma'am. She is MBBS MS DNB MRCOG from London and consultant obstetrician and gynecologist and infertility specialist and laparoscopic surgeon. She did fellowship in ultrasound, ART and gynecological endoscopic, having a number of national and international publications. We welcome you, Rashi ma'am. Our next panelist is Dr. Sunita Sharma ma'am. She is MBBS MD DGO and director of Jeevan Rekha IVF and Nursing Home Gaya, Bihar. She trained in IVF at Bloom IVF Mumbai and Nova IVF in the Kolkata. She is vice president of Magad Obs and Gynae Society. She is a faculty speaker, panelist, chairperson in many AICOGs and National ISAR, National IFS, AOBGS and other state level conferences. Our next panelist, Dr. Sadhna Sinha ma'am. She is MBBS DGO. She is secretary of Muzaffarpur Obs-Gynae Society, secretary ISOPOP Muzaffarpur, past treasurer Muzaffarpur Obs-Gynae Society, joint treasurer of AOGSBG and consultant at Apollo Maternity Jilla Parishad Muzaffarpur. We welcome you all and
Can I share my screen?
Yes, ma'am. Yes, Pratibha ma'am.
Can you see my slides?
Yes, ma'am. Yes, ma'am.
Is it full screen?
Madam, no, it is not full screen.
Now it is full screen.
Yes, madam.
Yeah. So, good evening, everyone. And
good evening, ma'am.
First of all, I would like to thank the organizers, especially Dr. MC Patel, sir, for such wonderful master classes which he's conducting for last 2 years. And last year also he had conducted in Bihar, and it was also very successful. Now again he has conducted this, and I'm very, very happy for sir that sir is disseminating such knowledge to all the Foxy members of our India. So it is congratulations, sir. And with this, I also want to give my regards to Dr. Rangila Sinha madam, our chief guest, then our guest of honor, Dr. Bharat Prasad sir, Dr. Esra Mitra sir, Dr. Esra Mitra madam, who has joined from Kolkata, then Dr. Ramadhar Tiwari sir, and so many stalwarts from Bihar and Jharkhand. My all regards to you all. And thank you so much for giving me this opportunity to moderate this panel. And now this is the panel on cervical cancer, and our my co-moderator is Dr. Kavita Barnwal. She is a very dynamic secretary of Bhagalpur Obs and Gynae Society. So welcome, Dr. Kavita. And we have 3 experts also. So Dr. Sneha Bhuyar, who is the ex-chairperson, Breast Committee, Foxy, Dr. Rekha Rajendra Kumar, Vice President, Bengaluru Obs Gynae Society, and Dr. Bharti Rajshekhar, President-elect, KSOGA. So if they are there, we'll be taking inputs from them also. And now I'll request Dr. Kavita to please introduce our esteemed panelists and just see all are there or not.
I think they have been introduced by Dr. Jyoti Bangrawala, but still I want to see Biba madam, you are there?
Yeah, Biba
madam. Yeah, Rashri Purve madam. She is also here. Leela Nardi is there. Santana.
Rashri Purve is not there. Dr. Rashri Purve.
But she had joined, I think. She had joined.
Dr. Rina is there. Dr. Santwana. Dr. Rina Singh.
She had joined.
She has sent an apology.
Rashi madam. Rashi
Yes,
madam, you are here.
Yes,
Sunita Sharma has written apology. Sadhana, you are here?
Yeah,
yes,
she's there.
Okay. So I think
Dr. Rashri is also there. Okay, so we'll start with this.
So I think 1 or 2 panelists are not here.
Yeah,
Rina madam?
Rina Singh is not there, and Sunita. Both
Yeah.
from
Both
Gaya.
from Magad. Both from Magad.
Yeah.
So, Rinashi, madam, okay, let's move. Yeah.
So what we are talking today is about cervical cancer. So that is a panel today, and I think so much we are talking about this and so much awareness has been done on this, but still it is an unfinished agenda. We all know that it is a preventable disease, but it is still not prevented, and there is death by because of lack of awareness and because of incompetence from both the parts, from the doctor part also and from the patient part also. Because what many a times what we see that hysterectomy has been done, but its histopathology has not been done, and later on it converts into cancer. Or patient reaches to us at the time when it is already late and we cannot do anything. So what we see that the humans are suffering from cancer, and mainly the females are suffering, and it is the 4th most common cancer in women and the 7th overall. And in India, I have first question for Dr. Vibha Verma, that what do you think, why these women are dying in spite of so many awareness and so much of talk has been done on cancer, and still we see every day that there is death due to cancer. So Dr. Vibha, can you throw some light on this?
Yes, Pranam Pratibhadi.
Hello.
I'm very happy to be part of this panel discussion. Actually, in our part in Bihar, we are dealing with very low socio-economic group as far as in medical college OPD is concerned. And they are not literate. They are not aware of anything. Their marriage is very early. They are exposed to sexual activity very early. They produce so many children. So they are exposed to this causative agent human papilloma virus very early, and they don't go for any screening test. Once they report to us, it is already very late. We try to do pap smear and biopsy, everything, but as they come very late in stage 3 or 4, so we are not able to do anything. We have to refer them for cancer hospitals. Most of them are not in a position to afford the treatment, even the travel expenses. So what is the end result? It is the death.
So very rightly said. And what is this Muhammad F. Fatala has said, who was the president of FIGO in World Congress in 1997? What he had said, which is very, very right, that women are not dying because of disease we cannot treat, but they are dying because societies have yet to make a decision that their lives are worth saving. So this is very correct in our Indian scenario, where still the females are the second grade citizens. They are considered, and most of the time they will look after their children, their husband, but they will not look after their own health, and many a times because of that neglection it happens late. Yes. So what we say, if one crash occurs, if one Airbus crashes, it becomes a news everywhere. We all come to know that that plane has crashed. But every day, almost 350 women full one Airbus is crashing every day in India, but still we are unaware of that. So that is the magnitude of the problem, and that is what we should look after. So the next question comes to Dr. Rajshri. What is I'll give this question to Dr. Kavita. She will take
Dr. Rajshri, madam, are you there?
Yes,
she's there. So we all know that incidence is very high, but still, I want to know what is the incidence of cervical cancer around the world and in our country.
In our country, this is the 14 per lakh in our country, and in around this is less. Mostly in the USA, this is very less in developed country.
So the incidence is very high, and in India about 1,22,844 per year as compared to worldwide, that is for 5,27,000. And mortality is also very high in India. It contributes 25% of the deaths due to cancer cervix, that is about 67,477, and it accounts for 23% of new cervical cancer cases in the world. So still
we are having highest number of cervical cancer cases and highest number of deaths, which is very alarming for all of us. So next, so yeah, so just I want to know from Leena Di, though all we know what is the cause of cervical cancer and what are the risk factors, but still to summarize, just enumerate the causes and how we
all
can
know. We
Yeah.
all know that cancer cervix is caused by the human papilloma virus. This was discovered by Dr. Hawson, and he has said his very famous statement that it is not possible to have cancer cervix until and unless there is long persistence of HPV DNA. HPV is the main causative factor for the cervical cancer. Around 100 strains are there. Of these, about 15 to 20 are oncogenic strains, and the most high-risk strains are the 16 and 18 variety. The 6 and 11 varieties, they are positive factors for the development of vulvar and other genital warts. And there are other factors also. Mainly the risk factors are because it is a sexually transferred disease. So if there is an early start of sexual activity, if a woman or a man have multiple sexual partners and they come from a low socioeconomic group, that is also a risk factor. And then presence of other sexually transmitted diseases like chlamydia, then other HIV. HIV is a very important risk factor. And women with HIV, they tend to progress to a higher lesion, a higher grade lesions very early compared to the other ladies. Then immunocompromised persons, they are also at risk for developing cervical cancer. Then poor hygiene, we can say poor hygiene is also a factor for cervical cancer. These are the various risk factors for developing cervical cancer.
Yeah, you are right, Radhi. Most of the causes have been explained. So any type of cervical inflammation, even HSV infection, herpes simplex virus infection can also lead to cancer cervix. And early marriage that you have well explained, these are the factors where we can see increased incidence of HPV infection and there were increased incidence of cervical cancer. So next. So this is the long history that we all know that it takes very long time to progress into cancer cervix, and we can make a halt in earlier stage or at the time of infection or at the time of CIN so that it doesn't progress to very invasive stage and we can save the mothers. So next. So you have been explained it. So now I ask from Dr. Shantana. So can it be eliminated? Do you think, Shantana, it can be eliminated because many society, even WHO has said that it should be eradicated from the world. Even our country government has said that it should be eradicated by 2029. So do you think that it can be eliminated? And if yes, then how? Shantana? Unmute yourself, Shantana. Unmute yourself.
Sorry. Thank you, ma'am. Yes, ma'am, it can be eliminated. And how? Because we should doctors, and also we should make aware to the patient that screening is very important. By screening, we can detect cancer at very early stages. And after, if it is detected precancerous lesion, if it could be detected and it could be treated at the same sitting while doing colposcopy, or it could be by ablation method or excision. So it is very we can treat it at very early stage and we can prevent it. But first of all, there should be awareness about early detection of cancer and screening of the cancer.
So you have explained it. So there are two opportunities that we use to prevent cancer cervix. First is vaccination. That is very important because today we are safe from COVID because we have taken the vaccine. So that is very important. Prophylactic HPV vaccination that should be given to young girls, adolescent girls, even to boys, so that they don't get any infection. Even they get infection, it remains mild. And another thing that you have explained well, that is cervical cancer screening. So just next slide. So this person, Herald Jur Hussain, he found that this cancer cervix is caused by HPV and
when he had got a Nobel Prize also for that. And when it was found that HPV is main causative agent of cervical cancer, then vaccine was started and vaccination has been done in many countries. Even low socioeconomic countries have started this vaccination in their national program, though our country has not done till now. But this is the need for vaccination, and that will be major factor in elimination of the cancer cervix. So this is, I think, natural HPV infection induces a weak response, while if vaccination is given, it will cause increased number of antibodies, humoral antibodies, and that will fight with the HPV human papillomavirus, and thus the patient, the girl, will be protected from the HPV infection. So this has been explained. So now Dr. Reena Singh, I think she is not here. So why vaccines should be given in younger age group? Anybody can take. Viva, madam?
We have our expert here, Dr. Rekha Rajan.
Okay.
Madam,
yeah, Rekha madam.
You can take this question.
Yeah.
Hello.
Hello,
Yes,
yeah.
madam.
Hello,
Yes, madam.
welcome, Dr. Rekha.
Yeah,
Yes.
namaste,
Welcome,
namaste.
madam.
Yeah. Please proceed.
Yes, this is for you. Why vaccine should be given in a younger age group?
I'm basically IVF specialist. But with whatever knowledge I know about the HPV vaccine, let me just talk, because all of us know that it is basically the HPV infection, as the previous speaker said about the different types of HPV and all that. And we all know that during the puberty time, the transformation zone, this is the most area, the particular area that is affected by the HPV. So, and that is the one later gets converted with conversion into the cells and becomes the atypia and all that. So that is the one which gets maximally affected. So in the puberty time itself, if the vaccination is given, it takes care of that part in particular. That is, the transformation area will be later on gets exposed outside. So before that itself, you have to take care of that. This is what my knowledge goes.
Yeah.
Sir,
So
it
you're
has,
right.
madam, it has to be given before the sexual activity starts.
That is what the transformation
right.
zone gets exposed later on outside. So you have to take care of that much earlier so that it is not affected, like the before the sexual activity.
Yes.
So it is said that the age at first intercourse is 5 times higher risk of invasion.
That is what I meant. I may not be very precise.
Okay. So thank you, Dr. Rekha.
It should start at the age of 9 and it should be completed by the age of 15.
Yes.
Then it will be 2 doses, and if we start after 15, then it will be 3 doses, 0, 1, and 6 months.
So these are certain cervical cancer facts which was given by Globocon. So Globocon is an online database providing global cancer statistics, which says that the cervical cancer is the 4th most frequently diagnosed cancer and 4th leading cause of cancer death in women worldwide. And what they found that from May 2020, less than 30% of low middle income countries had implemented national HPV vaccination program as compared to more than 80% of high income countries. That is also one reason of such high incidences in low income countries. Then only less than 44% of women in low middle income countries have ever been screened for cervical cancer as compared to more than 60% in high income countries. So this was the reason, and this was the Globocon in 2020 where they have given the Indian statistics, and they found that cervical cancer is the 2nd leading cancer among women in India, and it contributes about 20.5% of global incidences of cervical cancer and 22.6% global mortality due to cervical cancer all over the world. So that is the biggest chunk what we are giving from our India. So awareness and vaccination and screening is very important from our part, from we doctors' part, that should be implemented everywhere. So this is the question I think anybody can take. What is the global strategy for elimination of the cervical cancer? Anybody? Rashi,
Dr. Rashi madam. Rashi madam is there.
Rashi, you can take. Dr. Rashi?
Yes.
You have to unmute yourself.
there is three pillar of this eradication of the carcinoma of cervix. First, there is a 90% vaccination of the young girl. There is 70% screening of the adult female at the age of 35 and the age of 60. And third is 90% treatment of the treatment of the cancer patient. Proper treatment of the cancer patient.
So this is what WHO calls for world free of cervical cancer, and this is the statement given by Dr. Tadser, who was the WHO director in September 2018, said that every country must introduce and scale up HPV screening for women between 30 and 49 years old and ensure appropriate treatment and follow-up.
The goal is to get this by the year 2030.
30, yes.
And an incidence of less than 2 per 1 lakh women.
Yeah, 4 per 1 lakh women worldwide. This is WHO recommendation which has come that we should have vaccination 90% of the girls by age of 15, screening 70% of women twice in the age range between 35 to 45 years, and treating at least 90% of all precancerous lesion during screening. And WHO recommends screening of women between 30 to 39 years, either by visual inspection of acetic acid in low resource settings, or pap smear between 3 to 5 years, or HPV testing every 5 years, all coupled with timely and efficacious treatment of precancerous lesion. But again, American Cancer Society in 2020 has come up with different recommendation, and they said that the cervical screening should start at the age of 25 years and should undergo primary HPV testing every 5 years, and then up till the age of 65 years as preferred option. So that is what they are saying, that still when they started that with the 30 and 60 years, 49 years, they found that still many cases were undetected.
Being missed.
So they have decreased the age here and increased that side. So this is what has come. Now again, Dr. Rashi, this is for you. What is the resource-based cervical cancer screening recommendation?
Rashi madam?
You have to unmute yourself, Dr. Rashi.
Good evening, ma'am. The cervical cancer screening recommendation is that we have to start the screening. We can do the screening by HPV or by cytology also we can do. The modalities will depend on the resource setting of the place. If there is low resource setting, we can do via also. It is very good method for screening. And the age group will be after the age of 30, we start screening. And if the HPV comes as negative, then we can do the screening after 5 years. And for cytology and via, it is every 3 years we can do till the age of 65. And
yes,
frequency, how many times you must do? So it mainly depends upon where you are doing. Settings, if it is good resource setting, then you can do every 5 years and you can start with HPV testing. But if there is a limited source, then VIA is enough. You can start with this, and accordingly you can see. And every year, every 5 years, you should at least do screening. And it is said in the low resource setting, at least 1 to 3 times in the lifetime of the female should undergo some screening test of cervical cancer. That is what is the bottom line, that at least in our female patients, at least 1 or twice, at least 3 times she has undergone screening test. Now with this, we have come to our first case. This is Mrs. X, 33 years, para 3, living 1. Discharged per vaginum for 1 year, and her menstrual cycles were regular. On perispeculum examination, cervix was unhealthy. On bimanual examination, a normal size uterus, bilateral fornices was free and non-tender. And what they found after application of acetic acid, an acetovite area was seen on posterior lip of the cervix. So this is for Dr. Sunita, but she's not there. I'll ask
Dr. Leena. Dr. Leena,
Dr. Leena, you can take this.
She's
what is to be done next? Yeah.
She is showing an acetowhite area positive test on screening. So we should subject her to colposcopy.
And after colposcopy, anything else you can do? Because you have seen, you can take
and
a
biopsy. Biopsy.
Yeah.
Colposcopy and biopsy.
Yeah, so
Yes.
this biopsy was done and it came CIN1 with choleocytic changes. So now what you are going to do in this case?
We have to follow her up. She needs meticulous following up. And
Following up, do you think the CIN progress or regress? I mean,
CIN, the CIN usually it regresses in almost 57% of cases. It usually regresses. In 42%, 32% it persists, and it progresses in 11% of cases. But only less than 1% will progress to invasive cancer. So we have a very long period of time in which we can screen and detect these cases and treat them so that it does not progress further.
So what are you doing?
But I think in low resource settings we can treat also, because in our part
that is what we are
Yes,
coming
that
up
is
with.
what I was saying, that
We are coming up.
the patient is not very, I mean, she does not understand, and she will be lost to follow up. That it is better to treat at the first sitting itself rather than calling her for follow up and all. She needs following up and will need repeat testing.
I think Dr. Shadana Sinha is there, na? She can take this question.
Sadhana is there, yeah. You have to unmute yourself, Dr. Sadhana. Yeah. Are you going to treat this patient? You have to unmute yourself.
Sadhana?
आवाज नहीं आ रही आपकी.
She is there. Okay.
आप ये उतार लेते ना, डायरेक्ट बोलते तो आ जाता. हेडफोन उतार लीजिए.
First of all, what is the need for her fertility? What she desires, she wants to conserve, or everything we have to.
We are not going for hysterectomy in this patient.
Yes.
The patient is CIN1.
Patient is CIN1. So what
We are not going for hysterectomy, madam. We will call the patient after 6 months. We'll follow up and we'll repeat the pap smear and colposcopy can be done.
Yeah.
In many cases, it comes back to the normal stages we have seen.
Yeah, usually.
Yes, right. So you're
So
right.
this is what one study they have done, and they said that the safety of observation rather than immediate treatment of CIN1 was illustrated in randomized trial, where in the low-grade cytology, and they found that either the procedure, either LEAP or ablation, whatever was done, both were similar results were given. Either you follow up or you go for the procedures. That is what they say. But in our setting, we must go for some treatment if the patient is not, if his patient is not going to follow.
Ready to understand, yeah.
So
now the question
is for Dr.
yeah.
Vibha Verma.
Yeah, so what are the situation where treatment is required for CIN1? Vibha madam? So just you are explaining, so just you mention it. What are the situation where treatment should be required?
Patient should be followed up, and we can go for cryo or.
No. What are the situations where you are going to follow up, where you are going to treat the patient in CIN1? कौन से patient है जिसमें CIN1 में आप treat ही करोगे patient को? Treat करना ही.
या तो हम follow करें या हम treat करें. तो follow up कर सकते हैं. Otherwise treatment कहाँ जरूरत है कि patient नहीं आ रही है क्या? वो है question.
Follow up में if she is not, we think that she will not be coming up regularly, and if her HPV is positive, then we have to treat her.
Yeah, and I think she is right, but in certain cases, like there is
history is positive, it's not necessary to treat her.
That is not the necessity.
We have to follow up.
Yeah, follow up, or you have to see that the lesion is persisting for at least 2 years, or if it is worsening
for 2 years, or progresses to further grade.
And if it has ASCUS, it has a history of ASCUS, or it has gone higher, or in the immunocompromised.
Yes.
These are the
patients
conditions
with HIV.
Yeah. So
they should be treated.
Yes.
So these are the patients where if your patient comes with CIN1, you should not leave such patient. You must treat such patients. Okay, thank you. Yes. Now this is for Dr. Rajshri. How are you? How you manage such patients after treatment? Now you have treated the patient. Now how are you going to manage such patient? What are you going to do with her then, Dr. Rajshri?
You follow up this patient from by the pap smear, liquid-based pap smear, or by the colposcopy. And we in the case of the liquid base, you also do the HPV reflex testing. If there is HPV reflex testing is positive, then we do to the colposcopy. If the colposcopy is positive then we take the biopsy, and this biopsy is also for the diagnostic as well as therapeutic.
Okay.
I think, I think if the patient comes to with CIN1, then we will call her after 1 year and re-screen with either SPB or VIA or cytology, whatever is possible. And if it comes negative, she will return to routine screening like the 5 years interval. Or if it comes to be positive, then we have to go for colposcopy and do biopsy or any treatment procedure. So what is difference, Leena? Screen and treat versus screen, try and treat. So what is the difference between two?
The difference in these two are that in screen and treat, we screen, and if the screen comes positive, then without waiting for a second evaluation, we go for treatment. And in screen, triage and treat, we first screen, and then we subject them to a different test, a diagnostic test, and if they come positive, then we treat it. So this is the difference between the two, either screen and treat or screen, triage and treat.
And it was found that
triaging,
both the same result.
Result of the patients who will need treatment. Yeah. And those patients who will need treatment, they are to be treated.
Yes. So next, so this the flow chart. Anybody can read?
Anybody?
Viva madam, you want to read? So if the patient comes with CIN1 biopsies, what next? Just we have discussed.
So you have, that we have done that if it is HPV test positive or ascus or low grade lesions, then in that case, co-test with cytology or VIA at 1 to 2 years. If it becomes negative, then routine screening. But if it comes positive, then colposcopy and biopsy. If it comes CIN1, then again co-testing cytology, VIA after 1 year. If again it tests positive, then colposcopy and biopsy. And if CIN persists for more than 2 years, in that case, ablative procedure should be done or excisional procedure. If lesion not amenable for ablation or persisting CIN after ablation, consider excision procedure. And if it's ascus or high-grade lesions, in that case, co-testing at 1 and 2 years or cytology at 6 months. And diagnostic excisional procedures, again, you have to follow up as CIN1 management, that is, you have to go for ablation. And do. And if the colposcopy comes again CIN2 and 3, then again you have to follow same routine. So this is what FOXI GCPR guidelines in 2018 has recommended.
To summarize, if CIN1, we will go yearly for testing. If it progresses to CIN2 or 3, then we have to go for colposcopy and biopsy. Yeah. So even CIN1 persists. Madam is there?
Rekha madam? Rekha, you want to add something in this? Dr. Rekha Rajan Kumar?
Or Rekha madam has not come till now. Gomodni madam is there. You want to add something, madam?
No, you're perfectly fine. That is absolutely right.
Okay, thank you, madam. So this is another case. So it goes to Dr. Shantana. Yes, so this lady, 31 years old, para 1, complains of the persistent vaginal discharge and post-coital contact bleeding for 6 months. Her cycles are regular, but cervix shows an irregular area that bleeds on touch. So we all are seeing this case. So Shantana, how you are going to help her? What you will do when you find this type of case? Yeah.
I just on the patients have irregular menstrual cycle is regular. A patient on the speculum examination, cervix shows there is irregular area that bleed on touch. That is, cervix is friable, and it seems like a case of CS cervix. But first we should go for VIA, followed by biopsy.
I think
you should not label it
how can you label CS cervix? So
CS
first of all,
first
of all, we have to go for SPB test, VIA, and
screening. We should go for screening test, but I think as the cervix is a very service looks like irregular on a visual inspection.
Even ectropion also
can go
causes
for
Bleed on, it is a
colposcopy and
pliable
biopsy.
bleed on touch.
Trichomonas
So
infection looks like this only, strawberry.
ectropion also. If
Ectropion
there is
also looks
ectropion,
like
it
this.
bleeds on touch. There is history of contact bleeding. So just we can't say that it is cancer cervix. Just we have to go for the test, and if the test comes to be positive, then we will do colposcopy and biopsy. Thereafter, so see what the result has shown. The result has shown that opaque acito-white area and iodine negative. So it was found on the posterior lid. So now what we will do?
Excision biopsy.
Yes.
Yeah, the score, just we, I think we should share this score, SWADE score. So it is very important score, and depending upon the score, we should plan the treatment. So if the score is, so these are the criteria, acito uptake, this previous slide, what are the margins, what are the pattern of the vessels, what is the size of the lesion, and where iodine staining was brown, faintly or patchy yellow or distinct yellow. So depending upon the type, so what is the score? If it comes to be 0 to 4, then most likely it is CIN1. If it is 5 to 6, then CIN2. And if it is 7 to 10, then it is high-grade lesion or suspected invasive cancer. So this here, in this case, SWAT score was 8, and histopathological examination, which was done after taking biopsy with colposcopy, it was CIN2. So Dr. Rashi Madam, so what we will do? Treatment in this case. Rashi Madam, are you there?
Yes, ma'am. I would do a leap for this patient, and I would like to do a leap and a biopsy of the specimen. And after that, 1 year after that, we can do follow-up. If she comes as negative, she can return to routine follow-up of just like a general patient. In this patient, because he is high-grade lesion, I would like to do a leap procedure for this patient.
Yeah. What is the advantage of leap procedure?
It gives us a specimen for biopsy, and it gives most of the times it treats the high-grade lesion very efficiently.
Yeah, the entire transformation zone should be taken in the
Can be
biopsy.
removed.
Yeah.
And
That
the
is
margin,
most important. Yeah.
must be cancer free.
So anybody can take, what is the role of markers? Anybody has idea about the markers?
Yes, there are certain markers available, and by doing these tests, and if we get high grade, high risk types of HPV DNA or certain markers like Ki67 and all, if these are present, then they need to be treated.
So I think some marker, that is macro RNA 466,
yeah,
squamous cell carcinoma antigen, CA in case of adenocarcinoma, and recently this new marker P16 INK4A that has emerged. So what is the role? But still many publications have suggested that these markers have great role, especially in cases of
because
squamous cell
they
carcinoma.
indicate that the cell is going rapid mitosis and all. So it is better to treat these rather than waiting for screening again and then treating.
Yeah.
So now what is the, this is question for Dr. Sadhana Sinha.
Sadhana, you are there?
Yes, madam.
So just go through this question.
मैडम इट CIN 1 2 3 कुछ नहीं है इसमें ना?
नहीं, केवल CIN है, बताओ उसमें।
CIN है. If it is CIN,
yeah, then we'll go for this colposcopy, and if there's any positive finding, we'll take the acito-white area, or any positive finding, we'll take the biopsy. If it is negative in colposcopic finding, everything is normal, then we will, and the second test we are going to do for the HPV. If it is positive, then we are going to follow the patient regularly after 6 months or 1 year. And what else, madam, you tell us?
She was asking about the choice
yes,
options.
Choice.
Either excisional or ablative. We can go in for excisional therapies or ablative therapies. We have the loop electrosurgical excision procedure, then certain laser excisions like straight wire electrical excision of the transformation zone or needle excision of the transformation zone. Hysterectomy is rarely appropriate in CIN lesions. We can go in for cold knife conization. Then ablative procedures like thermal coagulation and laser ablation, cryotherapy. These are the relatively
So I
procedures
think for
available.
CN 1 and 2, thermal ablation is easily available nowadays. So
And
I
it
think
is very
most of us
easy
have.
also,
So this
and
is
we
very
should try
good thing, and we can treat at the same time. And if it is CN 3 or something
2
else,
or
then we
3.
have to go for a biopsy. So
Excisional
or
procedures.
hysterectomy even also. So Biva madam, what are the advantages and disadvantages of ablative procedures?
In case of a heat ablation we are doing, we are not able to do the biopsy properly because tissues are burnt. And in excision procedures, it is better. We can do the biopsy and we can know the extent. And we must see that the margins left are must be tumor free, because if anything is left, it will progress.
Ablative. In ablative, I don't think you
What
can
are
see
the
the margins.
ablative margins? How will you see?
You cannot see the margins in ablative procedures.
Yeah. So this is disadvantages of the
That
ablative
is
procedure.
disadvantage.
In menopausal ladies, already it is it recedes inside, so it becomes difficult.
So you have said rightly that the advantages are ablative procedure is very simple, cheap, widely available equipment we all have, effective when used expertly, and no expensive histological examination of the transformation zone. That costs another thing for the patient. And disadvantages are that the tissue is destroyed, so we cannot diagnose the condition, and it is not possible to rule out cancer or glandular disease if we only do ablative procedure. And also the depth of the excision. Although it says that 7 mm of tissue is excised, but still there is some doubt, especially with cryocautery, and margin status is also not known with the ablative procedure. So these are the disadvantages. So when there is, I think, diagnosis is uncertain, there should be excisional biopsy that will better tell us about the
Because
condition
it
of the
will
tissue.
give the biopsy report. I mean, you can go for the test and the report can come. But in this, the material you will not get, and there will be no reporting for it.
Rasni madam, so what are the conditions for ablative procedure? Yeah.
In the case of the CIN2 and also in the case of CIN3, we do the ablative procedure and conclude the transformation zone, and we also do the cone biopsy, and this tissue is sent for the biopsy to know the margin of this cone or a ablative tissue is either healthy or it is a infected area. If it is a positive area, then we do again the cone biopsy and again send to the laboratory for to know this this is positive or negative. If it is again positive, then we do the hysterectomy. If it is the negative, then we follow this case.
Yeah, so these are the conditions for ablative procedure. The transformation zone should be fully visible, either type 1 or type 2. It should be small enough to be covered by the destructive method probe, and invasive disease must be ruled out before doing any ablative procedure. There should not be any suspicion of glandular tissue, because if there is any suspicion, then if you do ablative procedure, the disease remains and it will spread and the condition will worsen. And there should not be disparity between the cytology report and colposcopy report, and there should not have been any previous treatment of the cervix for any condition, and there should not be upper or lower genital tract infection also, because this is a contraindication for ablative procedure. And patients should not be pregnant, because any type of ablative like especially thermal ablation should not be done in pregnant women. And if the patient has recently delivered, she should be at least 3 months postpartum. Then only we can go for ablative procedure. So these are the conditions where we can do ablation of the cervix. So next. Leena Di, so I think most of these things have been explained, but still, yeah.
First,
So I
we
think
get
we
the
should
tissue
move.
for proper biopsy for the histopathological examination. We can determine whether the margin is free or not. And this procedure is helpful especially in those cases where the endocervical element is more, which is not approachable by the ablative procedure. So this is the advantage of excisional method, and we can know about the status of the margin, and we can get a good, the tissue, I mean, including the whole of transformation zone.
Yeah. And
Okay.
Yeah, next. So
once you have
what
done,
next?
not next.
Yeah, Shantana.
Yes, ma'am.
Yeah, you have done ablative
after
procedure,
incision,
and what you do, what you will do next?
yeah, after incision procedure, the follow-up should be done at say 6 month after 6 months, and after 12 months, then yearly.
If test is negative,
If the test is negative, then she will return to routine screening.
Routine screening should be done, and if test is positive, then colposcopy and a biopsy should be repeated.
Yes.
You can go through this. Huh?
Yeah. So if the histology confirms CIN2 or 3, then we have to go for colposcopy. If the tissue is adequate, then we have done excision of the transformation zone. Then we will repeat SPB and cytology at 1 to 2 years. If the test is negative, then we will repeat SPB and cytology at 3 years. If again it is negative, then return to routine screening. And if the colposcopy report is inadequate, or if it is positive, or there is recurrent CIN, then we have to go for excisional procedure. And if the margin is positive, then repeat cytology and electrochemical cautery 6 months. Then we have to go for cone biopsy or hysterectomy if the family is complete and patient is not visible and patient is not going to come again, she is non-compliant. Then in these cases, we have to go for hysterectomy, especially in our part when the patient is not returning. And many a times we see, recently I've seen a patient, she was moving from here and there, and she was only 37 years old, and she had developed pyometra, and she was had clear cervix. So I think it's better if the family is complete and if she comes to be say 2, 3, and then we should go for hysterectomy. That will be beneficial for the patient and for us also. So next. So I think Pratibha has been taken more or less.
This has been taken. Chalo.
Yeah. So what are the, this is the question. What are the situation when there is increased risk of recurrence or persistence?
Maybe Dr. Ina is not there.
Older ladies, more than 40 years of age, in those patients who have glandular involvement, and cases where the lesion is very large, where the margin comes positive after, we have done excision and the margin comes positive. And if there is a immunocompromised state, especially HIV infection, in these cases, they will need further very meticulous follow-up.
Okay.
Yeah. So here
because
we should
chances of persistence is more.
Second smokers.
Smokers, yes.
Yeah, Viva madam is right. Yes, smokers, there is.
Yes, smokers and second smokers. Matlab wives of smokers.
And multiple partners.
Passive smoking also.
Multipara, low socioeconomic status, poor hygiene. I think these are the cases where we should go for complete hysterectomy if the family is complete, because they will land into major invasive disease.
Multipara and multiple partners.
Yes. Multiple partners तो पता नहीं, लेकिन multipara तो बहुत मिलती है हम लोग के, पता नहीं. Okay, next slide.
So कुछ any expert comment, Dr. Rekha?
Rekha madam is there. Yeah, madam, you want to say anything?
Rajendra Kumar.
Yeah, you have given comprehensively everything, explained everything. The very nice part of it was the treatment part.
Yeah.
Mainly, and second thing is that follow-up is very much necessary of those patients where especially the reports come negative. This is very, very important as a follow-up, because positive cases anyway treatment to ho hi jayega un logon ka. So that is very important. And another thing I would like to stress on is we have to explain and emphasize and take some time out of our practice to explain to all the mothers postpartum and also even menopausal ladies to tell about the vaccination for their children. Yes. Other than our school health programs, what we do very regularly about this HPV vaccination, we have to explain about it, because that is the age to catch them right.
Yeah, we have to apply, I think, some sort of flex or a banner in our clinics and OPD so that everybody can read and understand that this is the importance of vaccination and you should get vaccinated
And
your
second thing
daughters or
is,
any girl.
second thing is we have to tell them, because many of our patients do ask, pap smear and vaccination is same. Like they think pap smear normal आ गया तो vaccine का जरूरी नहीं है. We have to tell them बिल्कुल अलग है दोनों. कि vaccination also goes parallel. You should be happy that your pap smear is normal, but that does not solve your problem. That all the more you have to take vaccination to keep everything normal. The age group catching is very, very important. Plus, other than that, explain about pap smear is different from vaccination.
And even the pap smear is negative and patient is suppose 30-35 years. We can advise vaccination. Though she should go for a screening. But after vaccination, the disease burden will be less. Invasiveness will be less.
Yes.
So
we should keep screening these patients. Those who have taken vaccine, they also need to be screened.
In our place,
so that is what the awareness should be done, that screening is different thing and vaccination is different thing. You have to vaccinate. If vaccination has been done, that doesn't mean that the treatment has already been over. Or now you are disease free. You have to go for screening the way you have to. So that is very important. That should be explained to, because many times patients feel that I have taken the vaccination, now I will not have cancer. Or
other way around also. Other way around also. My pap smear is normal. I don't have to take the vaccine.
That is also there.
Also. Yeah, so and in Bangalore we have
next slide, Pratibha.
Yeah.
I think we should leave the case. Most of these things have been. Do you want to, because it's 9:15.
Okay, so now we will come to
rapid fire question. Yeah.
So what to do?
Anybody can take these questions.
Anybody can. Is
vaccine safe in pregnancy? Is not to be given in pregnancy.
Suppose the patient has taken
patient has taken and she has taken first dose and the urine pregnancy has come positive after 1 week. What are you going to do in that case?
चलता है, continue
Yes,
करो.
nothing to do after
delivery. Take at the interval of 5 to 15 months.
Yes. No, and what about the next dose? When is she going to take the next dose?
First dose
after pregnancy.
After delivery.
If the patient had taken a vaccine and she is pregnant, we should not advise MTP.
Yes. That is not to be advised.
Next.
In this case, 1 minute. In this case, do we consider the first dose is done or you have to start afresh?
No, first dose is done, second only. You have to give second dose only.
We have to give second dose only.
Okay,
now second, why HPV vaccine should be given in the younger children?
That has been explained that because of increased immunity and humoral response is there.
The vaccine is not going to
transformation zone.
Next
because they have a very active transformation zone. Younger children, they have a very active transformation zone, which is very susceptible to HPV infection. And if we catch them earlier before they start their sexual activity, that is the best period to vaccinate.
And immune response is also greater in young girls.
Immune response is also very high.
Younger girls.
These genes they produce more antibodies after HPV vaccination.
And that will contract the HPV virus, human papilloma virus. So it's better to give in younger age group. Yeah. Next. Next question.
Yes,
they have to be given to boys.
Mainly for the genital warts and other type of cancers.
Also given to the boy.
What is the dose schedule of HPV vaccine?
0.
Anybody can take 2 doses.
0 to 6 months.
And 1 for the girls up to 15 years.
Bivalent is 016 and quadrivalent 026.
This Gardasil 9 has come that includes 9 HPV strain and it requires only 1 dose. Gardasil 9.
No, that is Abhi, they are not recommending that. Abhi, we have to give 2 doses only. That has come.
But in younger age group, this is 0.
If we are giving in girls less than 15 years, we can go for 2 doses.
2 doses only.
Above
At
15,
the interval
we
of
have
6
to go
months.
for 3 doses. 0.6 for the bivalent and
in
0
younger
to
girls,
6
0 to 6 months and
Now,
0 and 6 months.
It is not available. Bivalent vaccine is not available. It is only Gardasil which is coming.
Quadrivalent and nanovalent.
Those is mainly
3 doses
9 to
above the
14
age of
years.
15 years.
2 doses, 0. First is 0 and second is between 6 to 12 months. 6 to 12 months.
Yeah.
After 6
And
months,
second, Second dose is for those 3 doses where we are giving, it is 0, 2, and 6 months. That is what
Yes,
is
but
recommended.
we are having Sarvavac at Muzaffarpur, and that is price is also very less. It is
Yes.
750
I have
for one
also,
dose.
I also have, madam, Sarvavac in our part. Serum Institute is making that vaccine.
Now it is coming up again. Single
It
dose.
is freely available at our place, and it is cheaper also, but it's still it is not in government schedule, and one has to pay 750 rupees for one dose.
But still, its cost has decreased, so we can give to patient and they can afford. So
Now what about Gardasil 9?
Gardasil is a costly vaccine. Gardasil is covering 4 strains.
But it has vaccination effect against 9 strains of HPV. So it's very good. And it can protect from the warts as well as the malignancy.
And it can be given for boys and girls both.
Yes.
Only one dose.
Also,
One dose is enough.
prevent oropharyngeal and laryngeal cancer.
Oropharyngeal cancer.
Anal cancer, oral pharyngeal cancer, everything is protected.
Now, what are the things which makes the vaccine stronger?
Probably that has been covered in the negative.
Certain adjuvants.
Archana, mute yourself. Archana, mute yourself. Dr. Archana, mute yourself.
So these are the things like certain adjuvants and the type of the vaccine that is being used. So these make stronger. So aluminum hydroxide is mostly adjuvant that is used for a Gardasil, and that is, I think, safer and also makes the vaccine stronger, because carriers should be stronger so that it can work better in.
And the type of strain.
BLPs are mainly. Purified virus-like particles which has to be there, which makes it more strong immunogenically.
And also the person who is to be vaccinated depends on the host condition also, whether the age of the patient, immune status of the patient,
anemia.
There is no contraindication as such for SPV vaccination. There is no contraindication. It is found that mostly should be given to even if patient has flu or something, some mild illness, she can take the vaccine.
Except that the vaccine does not prevent from sexually transmitted
they will
diseases.
show a robust response. Young patients, they will show robust response. That is what I'm saying.
Now, what about, now what should vaccine be given to a woman of 30 years?
Yes.
We should give.
Okay, but mainly it does not, below 25 they say it is better, but in 30, those who have multiple partners, in that case you must give this vaccine.
Can't eliminate her. Earlier would have been better. That's all.
Yeah, earlier it would have been better. Okay. So we have come to the end of this, and now this is the appeal by Dr. Kavita Barnwal.
So I am seeking your blessings and support. Everybody is here. So just I humbly request to support me. I am from Bhagatpur Society, smaller society, but I am working and I will work hard. So please support me. Rekha madam. So, most of members are from our society. So I think you are from.
Your neighbor will pay off.
Kavita madam and Pratibha madam, please do bless me also.
All the best for everyone who is contesting for this
various posts.
Yeah, I am Dr. Kalpana for Infertility Committee. Please.
All the best, Dr. Kalpana, Dr. Jyoti, Dr. Kavita. Anybody else? Join.
We humbly seek your support.
Madam.
Suman madam is also there.
I humbly request all of you to just for Ethics and Medical Legal Committee. I am going.
Okay.
Thank you.
So thank you so much to all esteemed panelists, and thank you so much for giving me this opportunity. It was a wonderful panel and wonderful webinar today. Once again, thank you, Dr. MC Patel sir, for giving us this opportunity.
I am not sick, sir. Oh, sorry, sir. Thank you, sir, for this opportunity.
Big round of applause for two learned moderators and all the panelists for making this panel very interesting and informative.
Thank you, sir.
Thank you, sir. Thank you so much, sir.
Thank you, sir. Thank you, sir.
To summarize, appeal on behalf of all the contestants.
Yes.
Kavita Barnwal for Urogynec Committee.
Yes.
Dr. Jyoti Banglowala, Ethics and Medical Legal Committee. Dr. Kalpana for Infertility Committee. Is Bharti there?
Yeah, Dr. Bharti is, she's not joined.
Yes.
No, Dr. Bharti is not.
Bharti for NCD.
Oh, Dr.
And
Bharti is also contesting. Achha, I didn't know.
No, another Bharti. That is from
Bharti
Karnataka.
Rajshekhar.
Dr.
No,
Bharti.
Bharti Rajshekhar.
Bharti
Yes.
Rajshekhar.
She is
She has
for
not joined. NCD.
NCD committee.
Okay.
Non-communicable disease.
And Dr. Suman. Dr.
And
Suman.
Suman
Yeah.
is for
Yes.
vaginal surgery.
Very good, sir.
And this is our track record that no member of our Happy Learning has lost ever.
Okay, thank you, sir. Thank you so much.
So
Thank you and all the
keep
best.
that tradition live.
Thank you,
Okay,
sir.
thank
Thank you.
Thank you so much, sir, for your
Just now
kind words, for your
nominate all of them,
blessings.
and at the time of voting, please vote for them. They all are hard-working person, and they will be useful in Foxy activity, in day-to-day Foxy activity. So this is my humble request for all of them. And
Okay,
Sneha is for Vice President West Zone.
Yes, yeah, Dr. Sneha Boya. Okay, sir. Thank you.
Okay, thank you.
Thank you,
Thank you, sir. Thank you, sir, for all your
Thank
efforts.
you and good night.
Very good
Thank you all.
webinar.
Hi, hi,
Bye.
Dr. Vibha. ठीक हो?
Thank you all. It was a great
Nilesh, we
evening.
can conclude or we can stop recording. Then chit-chatting will go.
Okay. Yes, sir.
Nilesh, we can stop recording.
Okay.
So
Yes.
questions from